Waqar, please. Please. Taimur, please have a seat, please. Adil. Rashid, please sit down. Bismillahirrahmanirrahim. Thank you very much, all distinguished guests. Now we are going to start this first Hyderabad Urology Conference, and the concept behind this is to improve the academic level of the PAUs and the Hyderabad chapter. And today is the first session, and the theme of this is the urolithiasis. So we're going to start with the recitation of Holy Quran. Can you please start this recitation?
بسم الله الرحمن الرحيم الرحمن بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان
صدق الله العظيم.
Now the national anthem of Pakistan, please start this.
Pakistan, before starting state-of-the-art lectures, I would like to invite you on the Professor Srinath Chandrasekhara to please come on the stage, and Dr. Mahesh Adhikarya, please come on the stage, and our worthy Professor Ayaz Khan, he is President PAUS, please come on the stage, and President PAUS Hyderabad chapter, Dr. Javed Altaf, please come on the stage. And to start with, I would like to request Dr. Javed to moderate these state-of-the-art lectures and invite the faculty accordingly. Thank you.
Bismillahirrahmanirrahim. Thank you, Kashif. So we are going to start our first session, state-of-the-art lectures. For that, I would like to invite Professor Morley. Is going to talk about changing traits in the epidemiology of the urolithiasis, Pakistan perspective.
Good morning, my colleagues. With the permission of Chair, the changing trends in epidemiology of urolithiasis is a difficult task. I tried to cover it, and I tried to include the studies from different areas of Pakistan. So it is poorly investigated, and incidence and prevalence is mostly based on hospital admissions. This is the adult stone clinic of SIUT, and this is a dedicated clinic for stones, and there are surgeon, physician, dietitian, and laboratory imaging, all are available in this clinic, and mainly 1200 to 1800 patients visit this clinic every Monday. With the westernization, the site of stone has migrated from lower to upper. Disease, once limited to men, is increasingly gender blind. Minimally invasive treatment remove the stone, but it does little to alter the course of the disease. Medical prophylactic program to prevent recurrence is required. To achieve this, understanding of epidemiology is necessary. Prevalence is varying around the world, 7 to 13% in North America to 1 to 5% in Asia. A rise in detection of asymptomatic stones diagnosed on computed tomography. This is a study carried out in SIUT. This is the population-based study on 1500 people. The prevalence was 109 to 8%, but there are two studies which mention 12% of prevalence by data from SIUT and data from AKUH. True incidence is difficult to comment. Number of cases increasing day by day. Data of two centers revealed phenomenal increase in stone cases. It is the 50% workload of urology, from 26,000 to 60,000 in 4 years, and from 95,000 to 189,000 in 7 years. And AKUH mentioned workload doubled in 12 years. This is data from HIUT, the data of 4 decades, and we can see that rising number of stones in our outpatient clinics. Risk factors start from age and ends at the education and occupation. Over the last few decades, stone disease in children is increasing at a rate of 5 to 10% annually. Epidemiologic changes such as obesity and metabolic syndrome more often affecting younger generations. Middle-aged population is more prone due to laborious work, subsequently drink less water and develop dehydration. In adults, the incidence of kidney stones peaks in the 4 to 6 decades as per international literature, but at SIUT it's the 2nd to 4th decade. In children, we see more bladder stones. As age advances, more renal stones are seen. Increasing incidence of stone formation in women. One of the striking new trends, incidence rate ratio changed from 3.4 to 1.3, and this disproportionate rise in women is related to obesity. A study based on 2 large cohorts, nurses health study in women and the health professional follow-up study in men, Kuran et al. Found that prevalence and incidence of calcium oxalate stone disease was directly associated with body mass index. The magnitude of association was significantly stronger for females than males. Similarly, the incidence odds ratio based on BMI for women was 1.89 to 1.19 for men. These findings were also confirmed by Nofer et al. They reported significant positive correlation between obesity and nephrolithiasis for both genders. However, obese females were more likely to develop stones than obese men. A study from Germany contradicted this and concluded obese men are more prone to stone formation than obese women. But one local study from Gadab performed in 3 centers, Lahore, Bahawalpur and Karachi, they saw positive association between hyperuricemia and obesity. The changing trends in male to female ratio is seen in this slide. It was 9 to 1 in 1971, a study by Shahjahan and Ataur Rahman, and it has changed over the years from 4.5 to 1.4, and one study from Nawab Shah mentioned male to female ratio of 2.3 to 1. Lifestyle and diet plays a role in stone formation. Mentioned by McCarrison in 1931 that cereals and vegetables which are high in oxalates are the culprits. Diet contains excessive protein, lipid, calcium and sodium also contribute. Precursors of oxalate in food like glycine, hydroxyproline, hydroxyacetic acid, vitamin C may be metabolized to oxalate in liver and subsequently increase the oxalate concentration in urine. Hyperuricemia can be the result of excess of meat and then subsequently uric acid stones are formed. This is the dietary patterns study conducted at SIUT. We can see that the stone formers are they are having less calcium, more oxalates, less fibers and less water intake as compared to stone controls. But there are changing assumptions in diet. A study by Taylor and Curran did not support a widely held assumption that increased dietary oxalate consumption in foods such as spinach posed a risk for increased incidence of urinary stone disease. They mentioned that more than 8 servings of spinach in a month compared to less than 1 in older women, it has relative risk, low relative risk of 1.34. Prospective study by Curran et al., they revealed that vitamin C supplementation, which may be metabolized to oxalate, was not associated with an increased risk in women. Coffee, tea and high sugar content beverages, a study by Curran showed that consumption of 8 ounces of coffee and tea decreased the risk in women by 10% and 8% respectively. In other study, the same team in their study of dietary risk factors, they concluded that higher intake of dietary calcium decreases risk of stone formation in younger women, and they propose that dietary phytate may be a new important and safe addition to our options for stone prevention. Higher prevalence of stone disease is found in hot, arid, and dry climates. Areas of high stone prevalence are reported as United States, India, Pakistan, and other countries. Due to unavailability of data, true geographical variation in incidence and prevalence worldwide cannot be reported. But McCorison in 1931 mentioned Sindh in Northwest Frontier Province, now KPK, and the Punjab great stone areas. Link between seasonal high ambient temperatures and increased risk of kidney stones worldwide has been validated, and increase of 1 to 1.5 million lifetime cases of climate-related urinary stones by 2050 will be a current day stone belt mentioned in recent edition of Campbell Urology. For every unit degree Fahrenheit increase in temperature, the percentage prevalence rate increased by 0.15 in men and 0.04 in women. This is the data from SIUT, and we can see that from March to November, we see more patients in outpatient clinics. However, whole year we see these patients in our clinic. Cardiovascular disease has a link with the stone disease. Hypertensive stone formers excrete about 25 milligram per day more calcium than normotensive stone formers. Stone disease is linked to cardiovascular disease. One study found 31% higher incidence of myocardial infarction. Cohort study of 3 million people in Canada revealed higher risk of cardiac disease like MI and stroke. More younger population and women are affected. Role of education level is not proved. Some advocate sedentary lifestyle as a cause of stone formation, and others favor a positive relationship between urinary stones and people with more physical work. Risk of stone in people exposed to high temperatures due to the nature of their job are more prone to develop urinary stones. Hot temperature may lead to dehydration. Excess exposure to sunshine results more production of vitamin D. Socioeconomic status is also an important factor in epidemiology. Both the extremes, well-to-do patient forms stones due to high caloric diet, and labor people doing labor jobs, they also form stones because of the exposure to hot weather and heat, and taking less drinking water. This is the data from SIUT regarding occupations. We can see that 50% of the patients were laborers, farmers, housewives, drivers, and cook, but we can see that office workers, teachers, and businessmen were also the affectees. Genetic has got a role in it. Cystine stones are caused due to mutations in the SLC3A1, SLC7A9 gene. Mutation of SLC22A12 and SLC2A9 also been reported with uric acid stones. Data suggest people with family history of urolithiasis more likely to develop stones. This is data from SIUT which shows that the family history of stone disease in stone formers, 37% has got positive history of stone. A beneficial effect of a high fluid intake on stone prevention is well recognized. Prospective randomized trial assessing stone recurrence between two groups, one with high urinary volume to control group, revealed that with the high urinary volume had 12% prevalence of stone as compared to low urinary volume group 27%. Relation between water hardness and stone disease investigated by researchers and could not find any correlation between two. This is the data from SIUT in transplant population. Out of 2,277 patients, 227 were stone patients with end-stage renal disease. They received renal transplantation. Only 2.2% formed renal stone in 20 years follow-up. The reason behind that they were educated to drink sufficient water to increase their urine output more than 3 liters. Endemic bladder stones are decreasing, but still in some centers they are prevalent. This is the study published by Shahjahan and Athoraman 1971 revealed 20% of these stones were bladder stones, and a study from SIUT mentioned 14% endemic bladder stones. One study from Navasha reported 42% bladder stones, and a study from Gambut Institute of Medical Sciences mentioned 56% bladder stones. But this is the changing pattern at SIUT that in 1987 to 1995 we saw 60% of bladder stones, and in 1996 to 2000 it reaches to 15%. This is again showing the changing pattern of stone location. In pediatric population, previously we were seeing more bladder stones, and as you can see that bladder stones have decreased and renal stones have increased in numbers. And the same pattern in adult urology, and previously we were seeing sufficient number of bladder stones, but number is decreasing and renal stone are there, and reason may be that we are treating now obstruction in adult patients, and the stones in upper tract are treated well in time. This is the practice patterns in different centers, data published by Aga Khan University Hospital, and you can see that this is also variable. In some centers there is significant number of open surgeries, in some centers less invasive procedures are done in significant numbers. And this is data from SIUT of last 4 years, and we can see that more and more less invasive procedures were performed. 4% had open surgery, and some patients underwent robotic pyelolithotomies. This is the metabolic studies in adult stone formers and controls, and we can see that in stone formers we see hyperuricuria, hyperoxaluria, hypocystaturia, and hyperuricemia as compared to controls. This is the study reported by AKUH. They reported separately the last 8 decades because of difference in composition according to site and era. Most are complex stones, and 1/3, 34 to 36% as a single component. Depending on the region, 16 to 70% of these stones may be single component. Our study at SIUT revealed 40% stones, single component stone. And this is very busy slide showing percent composition of stones from different areas, and we can see that calcium oxalate monohydrate are the most common stones. Then comes calcium phosphate, uric acid, and steroid. This is the frequency of compounds in upper tract, and you can see that calcium oxalate is the most common compound, and then comes the uric acid. And this is the frequency in lower tract. Again, we see more calcium oxalate stones in bladder as well. I will conclude, Chairman, that prevalence of renal stones is increasing exponentially in Pakistan. Gender gap is becoming narrow to 1.4 to 1. More female and old age patients are seen nowadays. Exposure to higher environmental temperature, low fluid intake, obesity, and positive family history are the factors, and they always hurt and they should be prevented. Thank you.
Thank you, Professor Morley, for having such a excellent talk and showing us valuable data.
Thank you.
We can invite questions. We have a few minutes.
Yes. Yes. You are right. Mentioned in studies, yes. Oh, you are right. You are right. Thank you. Thank you.
Thank you, sir.
Thank you, sir.
one question. What was the association between the hyperuricemia and the diabetics in your studies and making the stones?
There is no such study from SIUT, but the literature shows that there is association of hyperuricemia, diabetes, and stone. But what we don't have our own study on this.
So we are going to have our next speaker, Professor Hamad Attar from AKU, going to talk about the evolving role of thulium laser for urolithiasis in the developing nations.
Thank you very much, Mr. Chairman, ladies and gentlemen. So what I've been asked to talk about is the role of thulium laser fiber. And this is a talk that I have recently given in the expert in stone disease meeting held last year in Athens. The whole idea is that can we do better than the current gold standard, and which is holmium laser. And holmium laser has served us for the last 29 years, 1993 when it was introduced, and has served us very well. Indeed, we have seen yesterday as well live demonstration of holmium laser and its ability to take care of even larger stones that were previously cannot be managed by laser. So we know that holmium laser is a solid state pulse laser as compared to the liquid and the gas laser like carbon dioxide that we have. The frequency and the wavelength is about 2000 plus. It is strongly absorbed by water, so that's why it can be used in a medium where there is water in a stone, and it can also be used for soft tissue. The mechanism of fragmentation basically involves a photothermal and a thermochemical mechanisms, which provides excellent fragmentation. Your lasers are basically of two types: the low power generator laser that we have seen yesterday, and it can go to 30 watts, which is essentially what is needed for most stones. They can be high powered laser as well, which can be 120 watts, and it provides you a greater range of frequency and the energy levels that can be used to tailor your treatment. Now, why we need another laser system when we have such an efficient laser in the form of thulium, holmium? The thulium laser fiber is very similar. It's a solid state laser. It is frequencies just under 2000. However, its penetration depth in water is shorter than that of a holmium yak. I'll talk about it a little later, that why it is advantageous. It's 4 times more powerful than holmium, in the sense that the speed and operating time can be decreased. So this is one of the major criticism that we have for the holmium, that it takes longer for the laser to fragment larger stones. The laser diode is excited by a flash lamp, whereas in the holmium, whereas the mechanism is totally different for the thulium fiber laser. the problems that with holmium laser, that it's a huge machine. It creates a lot of sound because it uses flash lamp and water cooling system, and that requires a lot of gadgets within that laser system, which produces sound waves, which produces a lot of noise in the theater. Whereas the thulium fiber laser is different. It's a much smaller machine. It can be plugged to your regular wall socket. It is 1/8 the size, and with all this, it provides a much stronger laser system for urolithiasis than what is available for by the holmium system. So with these qualities and characteristics, thulium will become the gold standard for at least urolithiasis. The peak powers of 500 watts, it emits pulse energies which are very low, 0.025, and if you remember, for holmium we have the least, which is 0.2 joules, and it can go up to 6 joules, which is again not possible with our current holmium system. The frequency can be as high up to 2000 hertz, whereas for holmium the system is very different. It's 50 to 60 hertz that you can go at max. So with all these characteristics, TFL, the thulium fiber laser, ablate twice as fast for fragmentation and 4 times as fast for dusting. So with this, it provides you a higher ablation efficiency, better dust quality, and the dust is much finer than what you can get with the holmium laser. If you look at the machine specification, rather than the water cooling system, you have an electronically controlled laser diode, which provides a peak power of up to 500 watts. As I said, that the ability to alter your settings are much wider than what is provided currently by the holmium YAG system, and the pulse frequency can go up to 2400 hertz. There is a very long pulse duration, which is called the width, or the pulse width, which is an additional characteristics provided by the new laser system even in holmium. But the pulse width of thulium fiber laser is much longer, so it essentially provides you not interrupted but continuous lasering, and that significantly decreases the time of fragmentation. One of the major concern with the thulium fiber laser, with that kind of energy generated, is the temperature or the thermal effect. And in the initial studies, this was noted that it can increase the temperature within the system significantly. So the initial studies reported about 2-3 years back that thulium's higher absorption coefficient in water can increase the water temperature. The heat produced by 1 joules of TFL is 4 times that of holmium YAG. So for the same energy settings, your energy produced is much more. Subsequent work show that in clinical studies that there is no temperature difference between TFL and HYDERABAD as long as you're using in the low energy setting. If you're using it for the higher power settings, which is very infrequently required, the temperature can go up and it can produce effects unless you use the cooling system or the cooled irrigant and continuous flow irrigation in order to keep the temperatures down. It is particularly important for the ureters where your margin of error is low and you're very close, working very close to the mucosa, and there are possibility of development of strictures secondary to the heat effect. The finest holmium YAG fiber that we have currently is about 200 microns, which is 1/5 of a millimeter, whereas the finest TFL fiber available is 50 microns, which is 1/4 the size. And you can see that the size of the thulium fiber laser can have a significant advantage. First of all, that you would have significant space available between you in the working channel to allow irrigation fluid to pass through. You would have the ability to bend your fiber, you bend your scope much more than what you can do with the holmium, which has 200 microns. And the fiber characteristics are such that it does not produces any problem with the energy transmission, even if the fiber is completely bent. So these are some of the characteristics which can significantly improve the way we do our lasering for urolithiasis. The other factor which has significant cost implication is that there is less burn back, which means the consumption of the laser fiber that you see. So with less burn back, your fiber is likely to last much longer. As I've said, that the difference between 250 micron fiber has clear advantages, and these advantages will become more and more useful when we are able to miniaturize our flexible nephroscopes and use lesser diameter nephroscopes, which are less than even 6 French that we currently have as the finest RIRS equipment. So the stone ablation ability is important, because we know that when you're dealing with larger stones in the kidney, the dusting is the mode which you would prefer to do, because you don't want to go in and out of the ureter of the kidney time and again. And if you can dust bigger stones to a much finer dust, you'll be able to achieve stone clearance in a shorter time and without significant in and out from the collecting system. So this is one of the advantage which can make a difference in the years to come. Another important characteristics which is different from holmium. So if you look closely into the diagram below, you would see that if you are at a 0 millimeter distance from your target, which is a stone, the holmium yak provide 100% energy conversion, whereas TFL does the same thing at 0 millimeter. If you move 1/3 of a millimeter away from your target, the lasering energy is still about 1/3 of what it was at contact level, whereas the lasering energy decreases to 1.7% only at 1/3 millimeter away from the stone. And if you are 1 millimeter away from the stone, about 4% lasering energy is still there, but with the TFL fiber, there is absolutely no laser energy at 1 millimeter away. So you need to work close, which is an advantage in tight collecting system. And the safety of laser improves because your energy cannot be decimated and goes on to the surrounding soft tissue. So the collateral damage that we see on mucosa is less frequently observed in this study so far. So what is the history of this new laser system? It was introduced in Russia, and this is where most of the initial studies have come from. All the initial data has come from Russia. It was 2019 that the FDA approved TFL. The European CE mark was obtained in a year later. However, it is still a rarity in majority of the Western countries, and even and obviously more so in the developing world. India probably is one of the exceptions where the TFL is more easily available because of the local vendors. So in the years to come, hopefully things will change, and this system will be available much more widely. What is the current clinical evidence in support of TFL? And this study by Martov reported in last year in Journal of Endourology indicated that the lithotripsy results in shorter operating time compared to holmium, from 25 to 32 in a randomized study, randomized between TFL and holmium yak. a higher stone-free rate at 1 month proved on a CT done after using these two laser systems. So this is essentially an advantage, and this is our goal to achieve as good a stone-free rate as possible with minimal morbidity. In another study, the authors randomized 120 patients with greater than 5 millimeter, and the biggest stone that they've done is over 1.5 centimeters. So comparing TFL versus HUC, and there were no residual fragments in significant proportion. The zero fragmentation rate was better with TFL compared to HUC. The operating time was in favor of TFL, 49 versus 57 minutes in a randomized study. And one of the things that we see frequently is that after a short period, you have significant hematuria and the obscured field, which is also less frequently seen with TFL, and this is an advantage of its ability to have very little laser energy if you move away from the target. So there are many manufacturers besides the Olympus. The Coloplast also produce this TFL laser fiber, and they have also been tested both in vivo and ex vivo studies, and all these have shown that TFL is superior in those setups. Obviously, majority of these studies are small, and you still have to have a larger cohort of patients treated by thulium fiber to understand its limitation. Now, what about its adoption by our part of the world? And this is the question that the scientific committee asked me to address. Well, in view of few randomized controlled trials, we need to have ratification of the excellent preclinical data into clinical studies and larger studies from our part of the world as well. So we need good quality head-to-head randomized controlled trial. Although the clear advantages that we have at the moment is that it's lightweight, it's easy transportation. This is one of the advantage, because often laser systems in our part of the world moves from one place to another. Institutions cannot afford to have lasering system dedicated for specific work to one institution. So it's a very easy portable machine that you can take from one place to. The cost effectiveness is assessed by the capital cost and the maintenance. So the capital cost is not clear at the moment, but currently the data available indicate that it will be a much cheaper option compared to the holmium system. And the maintenance is also relatively less. Its energy consumption is also low, so it will. Now, when the question arises, which new technology should be adopted, we need to really ask two questions. First is, what's the cost of new technology, and what is the effectiveness of this new technology? So if the scenario one is that the cost is more and efficacy is low, then obviously you need to discard that technology. Whereas in scenario 3 and 4, if the cost is more and the efficacy is more, you need to run the cost-effective analysis, because it has to test the time. The fourth scenario, when the cost effectiveness is less and the effectiveness is also less, then obviously cost-effective analysis. But if you have a system which have a low capital cost, low maintenance cost, and is more efficacious than the current system, then obviously there should not be many questions about adaptation of this new technology into your setup. So in summary, Mr. Chairman, ladies and gentlemen, with the pulse energy of 0.025 to 6 joules compared to 0.2 to 5 to 1 joule, TFL has an advantage. Power going up to 500 watts, frequency of up to 2400 hertz, and a pulse width of 200 microsecond. The diode and the air cooling system, standard power outlet, all these in lightweight, it's only 30 kilograms. It seems like a promising future for TFL. There is significant improvement in ablation abilities, reduce operating room time, and TFL probably will emerge as one of a strong competitor for our current gold standard, which is holmium YAG. Thank you very much for your attention. Mike to Dr. Zafar Zaidi. Thank you. It's only for stones. Dr. Sajid Sultan.
In mind, you highlighted in your last couple of slides cost, but you say in future you expect the cost volume laser would be cheaper than volume laser. That's
no. What I said is
difficult for me to accept. And can you give me the reason for that? Because up till now, thulium is much more expensive than volume. Can I put all my questions?
Yeah, absolutely. Please go ahead.
Secondly, the efficacy or effectiveness of thulium, or as described, high power laser. On paper, it is very, very effective. But when you talk to people, I have not used 100 or 120 watts holmium, but when I wanted to buy a machine for my department, I looked around and I read a lot and searched a lot and discussed with us vendors. So I was told that in practical terms, the high power laser, 120 watt or 100 watt, doesn't help because they definitely break the stone very quickly, but the amount of dust they create, you have to wait for the dust to settle down, and then that's how it takes the same time. Whether you are using a high power laser, the holmium, or up to 80 watts or 60 watt laser, you get the same kind of outcome in terms of timing and stone clearance. So I am afraid that on paper this thulium laser is always appears to be more effective than holmium, but will it be the same when we practice? Because as you mentioned, until we have randomized controlled trials, it's difficult to get the right answer. Your comments on that?
Thank you. Thank you. Sajid, need to understand that I'm not comparing thulium laser from holmium laser. What I'm talking about is thulium fiber laser. Now, thulium fiber laser is different from thulium. The thulium basically is used like holmium. It's very similar to holmium, and it works very similarly as holmium. It works for soft tissue as well as for stones. This thulium fiber laser is only for stones, right? Now, when we look at the efficacy of treatment, we have to look at certain lasering parameters. And there are three important parameters in a laser system, which includes power measured in joules, the frequency measured in hertz, and the pulse width. Now, they all in various combination can be adopted to fragment a stone and individualize to that stone. So if you have a soft 6 millimeter or 5 millimeter stone, whatever you use, you'll be able to take care of that stone nicely. When you have a larger stone, you would be needing various ranges to be able to take care of that stone. So the surface would be different, the core of the stone would be different. The thulium fiber laser provides you that range. So if I'm using a holmium YAG laser with a setting, max setting, I have a 100 watt holmium laser. The lowest that I can go in terms of energy is 0.2 joules. And the highest that I can go with my hertz is 50. My start setting for a stone is 0.2 joules and 50 hertz with a total watt of 10 watt energy. Now, I don't need to use more than 20 watt energy for stones. So if my main aim is to have stone fragmentation, I don't need more than 30 watt laser. right? So you buy a 30-watt laser, which is a much cheaper laser, and use it. One of the problems that we face, because ureteroscopy, for stone in ureter, the thulium, holmium has a disadvantage that it has a significant propulsion effect. And with this, your stone goes back into the kidney. Whereas the propulsion effect is significantly decreased with TFL fiber. And the reason why it is decreased is that you can decrease the energy from 0.2 to 0.025 joules, which is a very, very low energy. And you increased your frequency. So the kind of dust that you create is something that you don't really have to worry about. It would pass out invariably. So these are some of the advantages about the literature, and I've talked about the randomized trials. There is a nice review published in European Urology last year talking about analyzing all the randomized controlled trial, and before 2020 we have all ex vivo studies, but for the last 2 years they have reported quite a few RCTs comparing head-to-head between holmium and TFL, and the results is very clear that the kind of dust produced is very fine. You don't really need to pick up all those small fragments, so I mean, in essence, if you have stone as your primary clinical need, then TFL probably will become the leader. All those RCTs, I said it clearly that all those RCTs are small RCTs, 50, 70 odd patients. We need to have larger cohorts so that we can deal with different types of stones of various composition. And as Dr. Mulli shown, that majority of our stones and our own data from AKU indicates majority of your stones are mixed. So you have to change the setting of your laser system during a single procedure. So in that sense, I think there is a significant potential of this system in the times to come.
How do you see the forces affect machine because they also reduce propulsion?
So I don't know if I've shown that slide about, if you compared the Moses on Moses type 2 with TFL, the propulsion difference, the propulsive effect, and is significantly lower with Moses 2 with TFL. And if you use the dusting efficiency, then again with Moses 2 or Moses 1, the dusting efficiency is much better with TFL than with even with the Moses. So Moses basically decreases your propulsion effect on the stone. So it's good that if you have isolated your stone into one of the calyx, you'll be able to complete the job in that calyx. Or if you are in ureter, then obviously there's a significant advantage that your stone is not going to go up and you have to use a flexible scope to complete your stone clearance.
Finally, why do you expect the cost of doing fiber laser to be less than?
Yeah, if you look at the capital cost, I'm not quite sure. Compared to a 30-watt holmium, it would be significantly lesser. But TFL has an advantage that its energy consumption is low, its operating time is low, its ability to clear a stone is higher. With all this, you have a cost-effective unit. So that's how science works, sir.
Excellent presentations, Hamad sir. I would just like to have one question. That is, if you don't have a laser unit in your setup, then you have a choice whether to buy a holmium or TFL. TFL has a better, outcomes as shown by the RCTs and all. If you have a holmium setup at your institute place, is it necessary to upgrade to TFL or not?
Well, if you have the money, you should buy it. But we all know that with Srinath sitting and yourself and all of us, money is an issue with us.
Yeah.
So it is a luxury to have two lasering system. if you're planning to buy one and your 90% work is stone, then I think it's more prudent to buy a TFL, which is going to be cost effective and it's going to be an efficacious unit. If you want to do, and if you really want to do some soft tissue work as well, then obviously you have to go for holmium. I mean, we have a holmium yak 100 watt for the past more than 10 years. And if I look at the percentage of its usage between soft tissue versus stone, I would say about 90% for urolithiasis.
But this TFL, I haven't used the TFL, but my friends, they say that they are very scared of using in the ureter because of tissue damage. If there is accidentally happen to touch this tissue, the damage is more than the holmium.
Yeah. So as I've said, that if you're using a high energy setting with TFL and you are in the ureter, then the heat effect is significant because the irrigation is not as easy in the ureter as it is in the kidney. You always have a fear of stone getting pushed back. So and the flow is also decreased because in initial phases your stone is completely obstructing. There is hardly any flow. So you're absolutely right that the energy going up in a ureter with little irrigation is an issue. So in that situation, you probably would end up using a very low energy setting and a very high frequency setting so that you are generating less energy. And you need to be not as close with the stone as you would require in holmium. So you can, even if at a certain distance, you probably would not be able to dissipate energy in the surrounding tissue.
Thank you, sir.
Thank you, Professor Hamad, for having such a productive talk on recent advances of laser. Thank you very much. So we are going to have our other speaker, next speaker, Professor Manzoor Hussain from SIUT, going to talk about problems and prospects of neglected urolithiasis in Pakistan.
So till this computer is operative, I would like to thank Dr. Javed Altaf and Dr. Kashif for this kind invitation and giving me this opportunity to present our data. So in this paper, there's nothing new like Dr. Hamad was telling us, Dr. Murli was telling, but this is all old urology, which is still we are facing the same cases which we are facing in the 19th century and in the 18th century. The neglected renal stones are quite common here in Pakistan, and I am sure the friends from India also share the same experience because of initial mismanagement and delay in the diagnosis. And there can be many factors, and the patient come very late, especially in the rural areas, with renal failure, with non-functioning kidneys and pyonephrosis. So in the 4 decades, as Dr. Mulli was telling about the data, there is an exponential rise in the number of renal calculi coming to the public sector hospital in Pakistan. I'm sure Dr. Javed and others also having the same experience, that the number of stones is rising. And we see on an average about 15,000 patients per year at SIUT, because SIUT has got now 11 centers, and it provides free facilities in the field of urology, nephrology, and transplantation. So more and more patients are being referred to us with stones with renal failure and stones with complications. MH neglected renal stones. Kashu. MH. Kashu. Neglected stones. USB. Sorry for inconvenience. No. Yeah. Sorry for inconvenience. So I start with the thanks and to my respect to my teacher, Professor Rizvi Saab, who is the founding director of SIUT. And SIUT is the largest public sector hospital in Pakistan, which provides free facilities in the field of urology, nephrology, and transplantation. And we have got 11 centers in Karachi, and 1 center in Hyderabad, and 1 center in Sakkar, all providing free facilities in the field of these specialties. So this is an old problem of neglected renal stones, and I think other developing countries like India and other Nepal are also sharing the same experience. So we discuss with this old problem in the new millennium. This is the stone clinic. We started it in 1989 with 20 patients, and those patients were followed after lithotripsy, and we jointly manage it by the urologists, surgeons, physicians, and dietitians on the various aspects of urolithiasis of diagnosis and prevention. And now we have got more than, as Dr. Mulli was telling, that 1,700 patients per week, a patient coming from all over Pakistan. And this is the data for 4 decades, and we have seen more than 100,000 patients. And as you can see, there was an exponential rise in the first decade, 3,000 patients, and in the last decade, about 60,000 patients. So there's an increased number of patients coming to the public sector hospitals in Pakistan. And on the one hand, there are recent trends, as we were listening to Dr. Hamad Atar in the morning. We have 70 lithotripsy centers in Pakistan and 58 PCNL centers, and we have 6 to 7 centers of laparoscopic surgery in Pakistan who are doing to some extent laparoscopy for stones. 3 robotic centers in Pakistan, one in Karachi, other is Gambut, and a third one is in the Sakkar. And flexible ureteroscopy is largely being practiced by all the urologists here in Pakistan. This is the standard mini PCNL using master lithoclass for this Stegan stone. And the nephroscopy has increased our understanding of pathophysiology of idiopathic calcium oxalate stones by Randolph specs, and we sometimes ablate it with the lasers to prevent the prevention of recurrence. And as URS, flexible ureteroscopy, is being adopted in every center in Pakistan nowadays. And similarly, there is a modern other recent advances in the diagnostics from X-ray KUB and ultrasound to the CT scan in Pakistan. So on the one hand, there are recent advances in the management, and on the other hand, we continue to see these complicated cases nowadays in our clinical practice. And so this is the trends in the morbidity of stone disease SIUT data from Pakistan. As you can see, the data from 1989 to 90, we see about 360 cases with these complications like renal failure, like pyonephrosis, like unilateral non-functioning kidneys. They constituted about 28%. And similarly, in 1991 to 2007, we had treated about 38,000 patients, and 12% presented with these complications. And in 2010, 9%. And if you see the data from year 2022, we have seen about 15,000 patients, and out of those, 1,700 presented with complications at our center, and they constitute 11%. Unfortunately, we continue to see the mortality with the morbidity in these patients to about 127 patients per year. And this is the etiology of ESRD in Sakkar and Ladkana, the relatively rural areas of the Sindh, and we see the stone as a cause of end-stage renal disease is on the top 25%. What's the message from this is that the stone disease is the risk factor for CKD, but with the regular follow-up of a stone patient with renal functions and joint management of urologists and nephrologists can prevent the CKD into ESRD patients. So we analyze the causes of neglect, and in majority of the patient, the poverty is the main cause in seeking the advice or consultation. Then the number 2 is the traditional healers or the homeopathic medicines, and the family physician, they don't refer the patient to referral centers and asymptomatic patients. So these are the causes of neglect in delaying the consultation of the treatable disease to a very complex condition. These are some of the stone dissolving drug advertisements, daily advertisements in the social media and the newspapers, and this is one of the important cause for delay in the diagnosis till the patient goes into complications as a renal failure and pyonephrosis and non-functioning kidneys. So the true cause for the neglect is really the poverty, and in Pakistan 30 to 40% are below poverty line, and there is an increase in the poverty line after this flood and raining and this climate change in Pakistan, malnutrition, poor health spending, and lack of modern technology at the doorstep, especially in the rural areas, is the one of the important cause for the neglecting these stones and presenting late. This is just to show you the data, how we manage it. These patients, if they go into the renal failure, the management differs from the URS and PCNL, other things. So we divide the management into initial resuscitation by doing PCN, DJ stents, and hemodialysis. And then, as you can see, for the definitive procedure, more than one procedure is needed, and multiple procedures are needed to make them stone-free. And in renal failure patients, if we relieve the obstruction, many patients, like more than 50%, they recover their renal function. So it's worth removing the stone rather than labeling in them as a end-stage renal failure. But you can see many patients, they need maintenance dialysis and renal transplantation. Unfortunately, in the stones with renal failure, mortality is high as compared to the stones with normal renal function. This is the data, another paper from Pakistan, Dr. Hamad Attar. He identified 12% patient with renal insufficiency, and he also of opinion that more than 2-3 procedures are needed to make these patients stone-free, and serum creatinine can improve after relief of obstruction. So the message is that the stones should be removed and obstruction should be relieved before we label them as an end-stage renal failure. This is data from Peshawar, who have done 150 nephrectomies, and 53% were due to stones because of initial neglect and initial delay in the diagnosis. And this is the paper from a colleague from India, and who said that the endourological procedures can be applied to these patients to improve the renal functions. And this is the paper from Ladkana, Dr. Jalbani Saab, Professor Jalbani Saab, he is here. He reported 66 patients from Ladkana district with calculus anuria, and he relieved the obstruction with ureteric catheterization. And it resulted in the as a life-saving procedure, and many patients, they improve their renal functions. So these are some cases just to show you the glimpse and how that what we see. This is a 43-year-old lady with from Badin, and she came with serum creatinine of 4.6. Urine culture was negative, and anatrophic nephrolithotomy was done, and she is now maintaining creatinine of 1.6. So these type of stones, I don't know the thulium laser is effective or not, or the PCNL can be done. I would like to invite them to share their experience in these patients. And this is the non-functioning kidney due to stone, which could have been removed and could have resulted in by the URS initially, but it came very late, and laparoscopic nephrectomy was done. And this is another patient who had bilateral Steghan stones, and we removed these stones by open surgery about 5 years back, and now he's maintaining creatinine of around 3. So these are some infective complications we see in the stone, perinephric abscess and XGP. And this is the bladder stone, a giant bladder stone leading to renal failure from Balochistan. Patient came from Balochistan. And we did first catheterization, and creatinine become normal, and open surgery, stones were removed by open surgery. And another patient from Sadiqabad, bilateral Steghan, and we removed the right stone by anatrophic, and creatinine improved, he is dialysis free. And this is just a neglected, forgotten DJ since 5 years. This patient had a DJ stent for some gynecological operation as a prophylactic, and she was not informed by the surgeon that she has got this DJ stent, and ultimately this was the only kidney, and she came with renal failure and a large stone in the bladder. and we removed it by bucketinous cystolithotripsy, and DJ stent was removed by URS. So these were the few cases, and this is the analysis in these patients of renal failure. Majority are mixed stones, as Dr. Murli was telling us, and 25 to 30% have got uric acid. So I think there's a need to study more uric acid nephropathy and damage by the high uric acid level in this country. And I was looking to the literature, and there was a paper from England that do stones still kill, an analysis of death from stone disease in 14 years. And they have noticed about 1900 stone patients they died there, and about 130 patients per year. And mostly patients were females, and mostly the cause of death was UTI and other complications. Similar to us, in most of our patients who have neglected stones were females, and mostly it was the infection and the renal failure as a cause of mortality. So this is one of the example of a calculous renal failure patient who needs multimodality treatment by urologist, nephrologist, and needing to dialysis and transplantation. And this could have been done if initially by the ESWL or PCNL or URS, but we get these patients very late with these complications. So to conclude, Mr. Chairman, in spite of all the recent advances which we have been listening since 2 days, we still get neglected renal calculi in our country, and this is on the one hand is a challenge, and on the other hand is a tragedy which we have failed to avert. And there are some few suggestions that we should have organizing public awareness programs from on the print and electronic media, so that patients should seek the treatment at an early stage. And there should be education programs for family physicians for the diagnosis and treatment of stones, and to refer them to the tertiary care centers. But if you see, the mostly 72% of the patient with these complications, they come from rural areas and from poor socioeconomic class, and there's a drastic need to open new comprehensive stone treatment centers in those areas, which should be equipped with modern endourological procedures, and also stone clinics to suggest these patients on the prevention of the stones, so that these complications, drastic complications, can be prevented. So thank you very much for your kind attention.
Thank you very much, Professor Malla, for having a fantastic lecture. We can invite only 1 or 2 questions as we are running short of time, please. No question? Thank you very much, sir.
Previous or
no, I think it's better than previous. If you provide the facilities at the doorstep of the patient, then they come for the treatment, and we get more and more patients. And in Sakhar, there's a high proportion of complex stones as compared to the Karachi. So I think there is a positive response of establishing clinic there, and the many patients are coming from rural areas. But there's a more need, because the number of patients is very high, and the clinics or the hospital centers are few. So there's a more need for these equipped or comprehensive stone centers in other areas also. But there's of course, there's a positive response.
Do you think screening program in areas which are endemic to stone formation would be helpful for this population?
I'm 100% in favor of screening program because by doing simple ultrasound in those areas which are high incidence areas, we can unearth the smaller stones and treat them at an early stage. I am 100% in favor of this screening program in those areas.
Manzoor sir,
Yeah.
from this August hall and from this conference, I think we should suggest the government of Sindh that in spite of ordering for the multiple robotic systems and other things, we are supposed to, I just endorse your point of view, that we should start the good kidney centers right from the Jacobad to Tata in every district headquarters. Then I think we can cater these stone problems better than these expensive instruments putting in our hospitals. Because in Sindh, only 3 centers are there who are catering the stone disease. Only either it is in the Ladkana, Hyderabad and the Karachi. So this is the issue. Patients are not coming to your clinics. So from this center, I think we should adopt a resolution to the government of Sindh that they should have good centers. And I have given this advice when we were sitting with the Chief Minister, with Professor Rizvi, that we should establish these centers and to solve the problems of the poor people who are not coming to the Karachi, who are attending the 2,000 patients in the clinic. They can't get their number even. Thank you very much.
I fully support or endorse this idea of Dr. Jalbani Sahab, that every district should have a comprehensive stone center, and government of Sindh is ready to help if the doctors come forward. The government is ready to help and to give the money.
Sir, I have a comment regarding screening. The principle of screening is that if patients with active disease are being properly treated, only then a screening program should be started to pick up the asymptomatic cases. Thank you.
Dr. Zaid.
Please, should be a last comment or question, please.
Sure. It's interesting that myself included, we all talk about stone management and very little about stone prevention. The amount of money that we are spending, the Sindh government is spending, everybody else is spending in treating the stones, far less is required to prevent them. And there has to be advocacy. None of us do that except for those patients who have actually had the stone and come to us, but none of us promote advocacy in how to prevent stones. We don't see any campaigns trying to tell common people what they should do or what they should not do to try and prevent stones. I think that's also an element which this organization and all of us should, that aspect, we should be being more actively involved in.
Yes, sure. I think the establishment of stone clinics, especially for the prevention, is the answer. For this.
Thank you very much. We are going to move on for our next session.
Thank you all. Cheers. Now I would like to call upon Professor Zafar Zaidi Saab. Please come on stage. Professor Nanlal Khela from LUMS, Dr. Kashif and Dr. Rashid. Please come on stage to start with the pediatric urology urolithiasis session.
Assalamualaikum. Thank you all. Now we'd like to start the pediatric urolithiasis session with the presentation of Professor Sajid Sultan from SIUT. And the topic is clinical application of metabolic studies in pediatric population.
Assalamu alaikum and good morning. First of all, I would like to compliment the organizers of this Hyderabad Urology Conference for taking initiative and the hard work, and starting with a very important topic in urology, that is urolithiasis. And thank them for inviting me and asking me to share my experience and talk about another very important area, that's implication of metabolic studies, clinical implication of metabolic studies in pediatric population, and what Professor Zafar Zaidi was just talking about. We should talk about not just treating stone surgically, we should talk about how to prevent it and look into more detail the insight of stones, why they are being formed. So this is urolithiasis, as we all know, is one of the oldest diseases known to mankind, and over the history, many learned person has worked hard to look into the etiopathogenesis and try to provide some medical management to prevent these stones. In the recent past, McCarrison did a survey in 1931 in subcontinent and looked into the causation and distribution of stone disease in the subcontinent, and he found that certain areas in this subcontinent had more stones, and certain periods have very little stones. And among the causation, he found that dietetic and infection and physiochemical agents were the main factors in leading to stone formation. Thirdly, that they thought that diet is the main factor for these stone formation in that study. As we all know, and we have been hearing since morning, there's increasing incidence and prevalence of stone throughout the world, except for Taiwan, which the trend is decreasing. And it's an exponential rise, about 10% prevalence rate in most of the countries now. And Pakistan lies in the area of stone belt, and that's what we see not just in adult. We see that 67% of our pediatric urology workload is urolithiasis. And we see a very wide spectrum of stone disease in our pediatric population, which include urolithiasis in infancy, patient presenting with large stone burden, bilateral stone disease, presenting with renal dysfunction, acute calculus and urea, with very sick patient, and then chronic renal dysfunction. Some are neglected stone, which Dr. Manzoor was talking about, with extreme of disabilities, osteodystrophy. We see stones with anatomical abnormalities. We see stones leading to infective process in the kidney, pyonephrosis, perinephric abscess, or xanthoglomerular pyelonephritis. With this background, we thought of looking or investigating the stone disease, and we thought that let's look at the etiology of our stone formers. Why do they form and why do they recur? So we thought that let's look at what type of stones which we have in our population, and we use FTIR, infrared spectroscopy, for our stone analysis. What we found that about 38% of our stones were pure stones and 62% were mixtures. And among those stones, the majority of the stones composition was calcium oxalate stone or ammonium hydrogen urate stones. And the others were, of course, infective struvite stones, uric acid, cysteine, xanthine stones, but in a very small percentage. But they were common in renal, ureter, or bladder. The same distribution was found according to the site. But when we looked at the stone distribution according to the age, we were surprised to see that the less than 5 years of age had more ammonium hydrogen urate stones. And as the age increased, we see less and less of ammonium hydrogen urate stones, and we see more and more of calcium oxalate stone, to the extent that by the age of 11 to 15 years, 64% had calcium oxalate stones and only 8% have ammonium hydrogen stones. And some of the older age group will have a core of ammonium hydrogen urate, and then on surface they will have calcium oxalate stones. So something changed in their diet or their other body milieu that leads to this changing pattern of stone disease. we looked at the demineralized stones, the calcium oxalate stones and ammonium hydrogenate stones. We found that the mostly organic matrix was seen in ammonium hydrogenate stones. And the demineralized calcium oxalate stones showed ghosts of crystal ghost and less stone matrix, which was confirmed when we did a scanning electron microscopy that abundance of organic matrix and small crystalline component was seen in AHU, and abundance of crystalline component with small organic matrix was seen in. So, and we all know that this stone matrix is formed of proteins. So we tried to look at the type of proteins in our stones by doing electrophoresis. And we saw that there was a marked difference between the number and size observed between the AHU and calcium oxalate stone proteins. And there was a different spectrum band, wide spectrum band within them. And the literature also tells that there are more than 1,400 types of proteins found in these stones. They have tried to narrow it down to 20 and then to 4. That's out of 4, 3 are more common as a promoters and 1 inhibitor, but there is no definite insight into it. And we have not been able to pinpoint exactly how to put an effect on them so that they don't lead to, because they help in stone nucleation and aggregation of crystals and stone formation. And they are supposed to be in response to some inflammation into the kidney or the body, because, and then it's an immune response. But that's what we know about these proteins. So we know that this, we have seen that the different kind of structure, what kind of stone composition we see in our population. We know that it's a multifactorial disease, it's a multi-genetic disease, so how to look into it? We know that the stones are formed as an aggregation with increase in number and size of crystals, and crystals are formed when there is a situation of supersaturation with low inhibitors in urine, or there's some element of cell damage, and that supersaturation state is because of certain changes in urine. It could be low volume, it could be hypercalciuria, hypocalciuria, hyperoxyluria, hyperuricemia, various things, or these changes in urine because of diet or environment, or because of genetic factor like cysteine or xanthine stones, which are purely genetic in nature. So in order to look into these factors, we thought of evaluating our patient, because patient comes in emergency as well as outpatient, and they need their routine assessment of height, weight, their basic investigation, their process of relieving their emergency problems. If they have renal failure, they need a dialysis or resuscitation, then they need decompression, and they need some more imaging, advanced imaging, and they need surgical treatment, and then we get stones and then we analyze the stone. But at the same time, we thought of looking into the risk factors like dietary risk factors and urinary risk factors. And blood risk factors. In blood, we usually ask for, apart from the basic test, we usually ask for calcium, uric acid, and of course their renal dysfunction, complete picture. But we only ask for parathyroid hormone or plasma oxalate when we suspect that they have some of the hypercalcemia for parathyroid hormone, or if the urinary oxalates are high, then, or the stone type on imaging is bilateral stone disease, severe stone disease, or nephrocalcinosis, then we would ask for plasma oxalate as well. But the first thing we do that when we are doing a basic urine analysis, we send a spot sample for crystalluria, we send another sample for qualitative test for cysteine, and that's how we can sometimes pick up the cysteine stone, which is rare in our population. We always ask as a basic test a uric acid, because if they have a low or no uric acid, then we suspect that they are, and if they are non-opaque, then it could be xanthine stones. Then we ask for, once this assessment is done, then we ask for 24-hour urinary studies. If we cannot collect those who are not continent, we may have to put a Foley catheter, or we go for timed urine sample or spot urine sample for calcium creatinine ratio and other things. So we did a prospective study in our patient population where we looked into the dietary risk factor or those who were stone formers and their siblings as controls who were not stone formers. And we saw a very peculiar difference in the children diet, that those living in the same conditions, in same socioeconomic background, they had different priorities. Some were more fond of meat and taking animal proteins, and those who were stone formers, they did not take that much animal proteins. They were taking pulses or legumes. Then they were drinking less water. They were having increased oxalate diet with chocolates, cola drinks. They were having more refined sugar, eat more candies. So similarly, when we did their 24-hour urine analysis, we saw that they were excreting higher concentration of urinary uric acid. They were excreting more oxalate. They were mostly, very few of them were so high that we could suspect that they were primary oxalosis. Majority of them were secondary oxaluria cases. And a lot of them had low calcium, urinary calcium levels, because they don't take dairy products, they don't take milk, yogurt or milk. So low calcium, they don't have enough calcium in their diet to chelate oxalate. That's why more oxalate is absorbed and more oxalate was being excreted in the urine. That's why they had that high urinary oxalate level. And as they were drinking less, so their urine volume was less, they had low sodium, perhaps they were having diarrhea. One common factor of those who were forming stones and not forming stones, majority of them had hypocitraturia, and we know that citrate is a very good inhibitor of stone formation, but it was not statistically significant. So a single lack of inhibitor did not cause a stone in those siblings, in their other siblings, and they were free of stones. So that means there were multiple factors working in those who were forming stones. Then we looked at the saturated studies in vivo crystallization of native urine of calcium oxalate formers. We saw that they had high bone risk index who were forming stones, and those who were not forming stone had low bone risk index. And when we added metaphylaxis like potassium citrate and added hydration, their bone risk index, those who were forming stone, decreased. And now this test can be done with a small volume. Initially this used to be done 200 volume urine. Now you can do a micro method with 2-3 ml. So this can be used as a practical purposes of the overall capability or potential of that urine of stone formation in calcium oxalate stone formers. Similarly, we tried to hypothesize why these ammonium hydrogen urate stones are being formed in our children. We saw that they had low animal proteins in their diet, and they were taking more wheat and germ cereals, which produces glutamine and high ammonia production and high urate production there. At the same time, a lot of them have diarrheal diseases. They were dehydrated, they were having low, high production of ammonia and decreased potassium because of diarrhea. And the increased production of urate and ammonia in these led to ammonium hydrogen urate. That was our hypothesis. And when we looked at the 24-hour urine values of only those who were forming ammonium hydrogen urate, we could see that there was a much more difference in them. They had a higher percentage of hyperuricuria. They were producing more ammonia in their urine. They had low sodium. Their urine volume was low. And that's supported our hypothesis of ammonium hydrogen urate stone formation. And then I'll come to the other more genetic type of stones which we see in our population: cystine stones, xanthine stones, and primary oxalosis, which are devastating and leads to renal failure and renal dysfunction, and much more higher burden of stone disease, bilateral stone disease. For my younger colleagues, trainees, I will give you a literature background of cystinuria. Cystinuria is a genetic disorder in the transport of amino acids: cysteine, ornithine, lysine, and arginine, which we call it as cola amino acids. Out of them, it's a transport mechanism defect. Out of them, the other three are soluble and therefore they don't form stones. Only cysteine are insoluble, least soluble, that's why they form stone. And basic cola transporter is a digenic polymer and molecule, and it's labeled by 2 cysteines, which Dr. Murli also mentioned in his talk. The 2 genes are now identified, SL3A gene and SLC7A9. And these 2 genes or proteins are joined together by disulfide bonding. If any mutation takes place in these, either of the gene, then the transport system is altered, and you have a lot of cystinuria. 85% of these patients are because of any mutation in these genes. In literature, you see that up to 10% of these, their patient population is cystine stone formers. We have less number. Perhaps overall they don't have that much stone disease. That's why their relative percentage of cystine stone formers is much higher. The inheritance of cystinuria is a complex disorder that may vary from autosomal recessive or autosomal dominant, and the 2 can be combined together. And the combination of the 2, that means 2 recessive genes can have AA genotype, the other 2 can have BB, and A only as an autosomal dominant. So these different variety of genetic combinations can clinically represent cystinuria in a different way. Some have excrete very high percentages of cysteine in urine, some will excrete less percentage of cysteine in urine. Some are homozygous, some are heterozygous. So that's why they behave differently, they present differently. Some have less stone formation, less recurrence, some have very high recurrence rate. And you can do a quantitative test of urine and then that's how you can judge, or you can do genetic study and you can anticipate and you can predict the kind of risk factor they have for stone formation. We see these patients very early, in less than 5 years of age, they come, and a lot of them will come with renal dysfunction. The majority, 71% came with bilateral stone disease. They had a lot of stone disease. Recurrence rate was high in these patients. And as you know that there are harder stones relatively, and they are not amenable to ESWL. So either minimally invasive surgery, preferably minimally invasive surgery like PCNL, because you see a lot of open surgery. It's in the early era when we used to do for larger stones, we were doing in children open surgeries. But now even for larger stones, we are doing PCNL and minimally invasive surgery. So preferably they should be treated by minimally invasive surgery like RARS or PCNL, particularly if it's a large burden by PCNL, because children have a long life to live. There is a high risk of recurrence, so they may require repeated surgeries. You can't do repeated open surgery in these cases. And you have to keep them on metaphylaxis. And the metaphylaxis include firstly diluting the urine by hydration, and then keeping a urinary pH, because they do precipitate in less than 7 on a urinary pH of less than 7. So you have to keep a pH of 7 and above. So what we do that we provide potassium citrate free to them, and then we provide them a reel of litmus paper and teach them that please keep checking your urine, your baby's urine or child's urine with every time, and you should titrate it and keep the urinary pH above 7, and that's how that you can have an effective metaphylaxis. We all know penicillamine and alpha-mercaptopipronil glycine are there for a long time, but these are toxic drugs and seldom used. But now newer drugs are coming up, just like pharmacological chaperone therapy, and we hope that they will be more effective for these patients, and we will have a better treatment available. Now coming to hereditary xanthinuria. It's an autosomal recessive disorder. There are 2 types, type 1 and type 2. There's a wide variation of incidence, 1:6,000 to 1:70,000. The reason being that it's an autosomal recessive disease. In those countries where they have consanguineous marriages, the chances of having xanthine stones are much higher, like Pakistan. And those countries where they don't have consanguineous marriage, they have a very low incidence of xanthine stones. They are purine stones, so they are radiolucent stones. Until unless there is some calcium deposition, then they can be radiopaque stones. and they present with hematuria, UTI, or colic, and sometimes they present with myopathies and arthropathies because of the deposition of xanthine in soft tissues. So you should keep in mind when these patients are complaining of, you should not ignore it, you should consider it as a part of xanthine stone disease. The diagnosis initially can be simple. As I said, we always ask for serum uric acid. If we see that serum uric acid very low or there's no serum uric acid, then you can suspect a xanthine stone disease in the child. A baby coming with a xanthine stone. So, and then you can see a 24-hour urine or spot urine where you see again a very low level of urinary uric acid or no urinary uric acid. That also gives you indirect evidence of xanthine stone. The other ways of diagnosing between the different type of xanthine stones, type 1 and type 2, one of the tests historically was allopurinol stress test in type 1, and there are some metabolite excreted in the urine, 2PY and 4PY, which are done by HPLC. That's a research tool, not easily available everywhere, but the advanced lab, they do have HPLC facilities, so they can do these. Otherwise, you can confirm by genetic studies the different types. But these xanthine stones are not that hard stones, so they can be managed by ESWL as well. Again, these patients presented, 70% of them presented less than 5 years of age to us. Majority had bilateral stone disease, more than 50% of stone disease, and diagnosis was simple because by doing a serum uric acid level, their mean serum uric acid level was very low. Similarly, urinary uric acid was very low, so we made a diagnosis, and then the stone analysis confirmed the diagnosis. So we have not done genetic study or allopurinol stress test or metabolites in urine, but that's how we have diagnosed. Again, there is no specific treatment for
1 minute.
Just, okay, last few slides. So, again, hydration is the best treatment for them, or try to avoid consanguineous marriages, particularly if you know the history. And the other can be alkalinization, again, that can help in, but not as effective as it is in the. Coming to primary auxiliuria, there are 3 types known. Type 1 is the main, and this is lack of enzyme production to metabolize oxalates, so that's why there are a lot of oxalates. This is primary auxiliuria, and a lot of oxalate is excreted in the urine. They combine with calcium and form the stones, and they lead to nephrocalcinosis, nephropathy, and stage renal disease. And one thing is about, if you do a kidney transplant in early stage disease, just alone kidney transplant, there will be rapid recurrence. We have seen in day 1, you can see a rapid recurrence. So the only option, either you do a combined kidney liver transplant, or sometimes sequential liver kidney transplant. You do a liver transplant first, and then immediately you can keep the patient on dialysis, and then you do a kidney transplant. So these are the options. Bifringent crystals are hallmark. We have seen that when we, this is major deletion of AXT in the EXT gene. We have sent some nephrectomy samples and wedge biopsy samples in our kidneys where we suspected primary auxalosis, and then we correlated it with the genetic study. 80% of them were type 1 according to genes. 2 of them were type 2. We didn't have any type 3, but there were 4 patients who were not type 1, 2, or 3. That means there are, and people are still suspecting there may be some other types of primary auxiliuria, so perhaps those patients were other types of primary auxiliuria. There are newer drugs which have come up, otherwise the initial treatment was hydration, alkalinization, and beta-6. In some cases of primary auxiliuria is effective because it helps in transportation of that enzyme. Oxalobacter fermengens came long time back, was not effective, but this lumisiran is FDA approved now, and it is being marketed, very expensive, but is marketed in the West. So this can be a breakthrough in medical management of primary auxalosis, lumisiran. So then the surgical treatment I've already explained. This is one of our patients who had combined liver kidney transplant. And to conclude, pediatric urolithiasis has an increasing incidence and prevalence worldwide, including Pakistan, which put huge socioeconomic burden, constitutes 60 to 70% of the pediatric urology workload at SIUT. Urolithiasis is a complex, polygenic, and multifactorial disorder. Metabolic disorder contribute to 80 to 90% of the cases. There's some kind of metabolic disorder in children, whether they are obstructive uropathy, whatever. Along with that, they have some kind of metabolic disorder, as if you do there. So it is mandatory to do this metabolic analysis in every children particularly. Children have high probability of recurrence in the long run, and they have a long life to live, so you have to protect them from stone formation. Evaluation of metabolic disorder and its proper management can prevent recurrence. Let me tell you, ammonium hydrogen urate stones have very low recurrence rate on its own. Something changes when child is grown up more than 5 years or so, and then we don't see, very rarely we see ammonium hydrogen. So something changes in their body milieu and their body dynamics and their diet or whatever, their living condition. But for calcium oxalate stone, we have to look into the risk factors, and then we have to try to avoid them and prevent recurrence. Thank you. One more announcement I want to make. Please mark your date for 27 November to 2nd December 23. We will be having Asia Pacific Association Pediatric Urologist meeting at SIUT Karachi, Pakistan. There will be a pre-Congress live surgery workshop, and then there will be a conference.
Thank you, Dr. Sajid. Thank you very much for nice presentation and question answer session.
Only we'll allow one question because of the time. So whoever raises the hand, join kar lo isse sawal. Mike le le.
As you mentioned, there's a long list of battery of investigation, and most of the time, most of these tests are not being done or available at a public sector hospital. And even if we do it, and we do it routinely, in the most patients we are unable to find the underlying cause.
You are unable to find?
Underlying cause. The most common patients are the calcium oxalate stone or mixed stone. So my question is, after doing this all the expensive tests, how much we have been successful in prevention of these patients on the basis of these high-tech investigations?
There's no high technology. These are basic tests, biochemical tests, personally. So I think we can provide those tests. We are able to identify hyperuricosuria, hypocalciuria. These are, or sometimes urinary oxalate levels are high. No, that's a very high percentage. If you see one by one, then you are not going to find all these abnormalities in one patient. But some patient will have one, some patient will have the other, and some patient will have third kind of a problem. Even that, stone clinic effect is a very famous effect. Just focusing on them and advocating them that adequate hydration, keeping the color of their urine white or light yellow, you can easily teach a child and their mother these things. That please give him adequate hydration and keep a watch on the urine color. It should be light yellow or white. So that means they are adequately hydrated. Giving in calcium oxalate stone, which is in a higher percentage, or those who are not in infective stone, but in other stones, even uric acid stones or AHU stone, potassium citrate syrup, which is not, in market it is very costly. But if you prepare it yourself, it is very cheap. We deliver it free to our patients. And these two factors, and some of them can be held by allopurinol, which is again not a very expensive medicine. So these three combination effect can help many patients. Three, adequate hydration, of regular voiding, of course, and potassium citrate, and some patients need allopurinol because of hyperuricosuria. And then you ask them if they are excreting less calcium and more oxalate, you should take a dietary history and encourage them to take more dietary products. calcium product like milk and dairy products. So these few factors, I think you have to focus on every patient.
Right.
You have to teach your trainees for that. People should, the stone disease is one of the common, and you have seen the sequelae of stone disease in our population. They come with.
Thank you. And I think the 3 points he's mentioned: increased fluid, dietary counseling, and potassium citrate. You can probably do without doing the test as well. So anyway, thank you. We'll move on to the next speaker.
Thank you very much. Now we'll ask Dr. Ejaz Ahmed from Shifa International kindly present the presentation of calculus A and urea management strategy for better renal function outcome. Dr. Ejaz.
While we are getting ready, if anybody wants to ask questions, please use the mic in the middle of the hall, ताकि इधर उधर लेके जाना ना पड़े. I request कि जिसको जब भी सवाल इनसे पूछना होगा, use the mic there. Thank you.
Bismillahirrahmanirrahim. Mr. Chairman, dear colleagues, Assalamu alaikum. Thank you, management of Urology Department of Hyderabad, and particularly Kashif for asking me to present humble on this topic. I'm not going to, Kashif, I'm not going to forgive you for giving this an extraordinary topic, because when I looked into the literature for calculus N, management of calculus N urea from urology perspective point of view, I couldn't find much, because this procedure done by urologists is very simple. You just put divert the urinary system and then hand over your patient to the pediatric nephrologist. Then I understood that actually what is in his mind. I was expecting that most of our participants would be our trainees, and in majority of our setup there is pediatric nephrological services are unavailable. So you need to treat your patients as a physician, as a nephrologist as well. So I focused my topic from urology more on nephrological point of view rather than urological point of view, because in calculus you're nothing special high-fi can be done from urology point of view. So acute kidney injury or anuria is defined as a rapid deterioration of renal function resulting in retention of nitrogenous waste and biochemical derangement. This is one of the definition present in acute kidney injury network. And another definition from the kidney diseases improvement and global outcome presents that if there is oliguria of or urine output less than 0.5 ml per kg per hour for 6 hours or anuria, then this is the most prominent feature of acute renal injury. In tertiary care hospital, that about 1.5 to 2% of all pediatric admissions are due to acute kidney injury. And almost in ICU, this incident goes up to 20%. Traditionally, we classify acute renal injury into pre-renal, renal, and post-renal groups. And amongst post-renal group, the stone disease is the most common culprit. And among the post-renal causes, the most common cause, AKI is the commonest cause is kidney disease in almost 30%. And in children, this is a catastrophic condition because the metabolic derangement and the sepsis are very common in pediatric age. And the calculus inuria is most commonly seen in very small children. So there are tiny reserve of electrolytes, and they easily develop the sepsis, and the condition increases morbidity and mortality. And luckily, if it is treated on time, most of these patients can gain their normal renal function. And if there is any delay in treating the condition, some of these unfortunate kids may develop renal parenchymal disease or chronic kidney disease. There are multiple challenges in treating the patients with acute kidney injury due to calculus anuria. The particular risk I already mentioned is sepsis and electrolyte imbalance. And sometimes the stone location is difficult in pediatric, in particularly in extremely small children, because CT scan is not sometimes it's not that much sensitive as compared to the adults because of low fat content and motion artifacts, as well as sometimes they needs to be sedated, and if conditions are very critical, it's very difficult to sedate them. And the risk of decompensation during anesthesia and during procedure is very high in these unfortunate children. The clinical feature of calculus anuria is low to commonness is low to zero urine output. They may present with nausea and vomiting and with fever, and in older children may present with pain, altered sensorium, shortness of breathing, and they may present with hypertension, or if they are frank sepsis, they may present with hypotension as well. In laboratory investigations, the septic markup and other renal function investigations are important, but urine culture and urine RDs most of the time is not possible because if there is no urine output, but if there is, in case of urine output, they should be done accordingly. In imaging modalities, sonography is the first treatment to visualize the renal parenchyma, and this will give us the what is the type of renal failure. It is if it is pre-renal, post-renal, or parenchymal disease. And once there is a suspicion of post-renal obstruction, then the CT without contrast is an excellent investigations, and it not only gives you detailed anatomical description, but it also tells about the size and site of stone. In management point of view, the basic principle of management includes treatment of the life-threatening complication. The most common aspect is the fluid and electrolyte imbalance. Nutritional support, they need antibiotic according to status and in your hospital antibiogram, unidiversion, and ultimately definitive procedure. The immediate and life-threatening complications in acute kidney injury requires particular attention. These are sepsis, hyperkalemia, pulmonary edema, severe acidosis, hypertensive emergency, and anemia. If there is fluid overload, then fluid restriction is the first action to be taken, and the insensible loss should only be replaced with 5% dextrose water. But if there is hyponatremia, then you can add half saline as well. Monitor losses appropriately and should be replaced appropriately. When I was looking into the get-go guidelines, the role of furosemide is controversial nowadays, but because most of the centers we are still using it frequently, so I did not recommend to change it unless we do not follow the particular guidelines. In the other life-threatening condition is in these patients is metabolic acidosis, and they should be treated with IV soda bicarb. Watch for fluid overload because soda bicarb contains a lot of sodium, and they may develop hypernatremia. And in life-threatening acidosis, dialysis is more is required in some of these children. Hyperkalemia is really a dangerous condition. There are various ways to do depotash. The commonest mode of treatment is to infuse calcium gluconate at dose of 0.5 to 1 ml per kg over 5 to 10 minutes. And salbutamol nebulization is another method to reduce the serum potassium level. Glucose with insulin infusion can also be given in certain cases. And calcium resonance K-xylate is also an effective treatment to reduce the serum calcium level. And unfortunately, K-xylate causes constipation, so it's better to give perfectal than then given orally. And in recalcitrant cases, immediate dialysis is important rather than treating them with medication. Most of these patients are anemic, so they cannot be transfuse blood in normal doses. Normally, the permissible blood dose is 20 ml per kg, but in packed red cell 10 ml per kg is allowed. But in case of fluid overload, maximally 3 to 5 ml per kg packed red cell is given. And in severe cases, blood should be transfused along with hemodialysis. Sometimes these patients present with hypertension, and that should be treated with IV. If they are symptomatic, they should be treated with IV nitroprusside, or if patient is asymptomatic, then that can be treated with oral medication. Pulmonary edema requires oxygen supplementation. Furosemide already mentioned. And dopamine in low dose not only improves the renal blood flow, it also alleviates some symptomatic pulmonary edema. But again, KidGo in the latest edition in guidelines, they do not recommend giving dopamine for this purpose. And again, the hemodialysis is the mode of treatment. Is pulmonary edema is very severe. The indication of hemodialysis or pulmonary, the peritoneal dialysis are uremic symptoms with altered sensorium, abnormal behavior, seizures, or pericarditis, or very severe hyperkalemia associated with ECG changes. If there is severe acidosis which do not respond to a traditional treatment, or if there is very high fluid overload, and there is severe anemia, and in the last is the malignant hypertension. All these are indications for hemodialysis or peritoneal dialysis. Remember that the ultimate outcome doesn't difference where the child has undergone hemodialysis or peritoneal dialysis. In fact, in very small children where in most of our setup where hemodialysis is not possible or service is not available, peritoneal dialysis is as effective as hemodialysis. So this should not be omitted. In certain cases, if there is hyponatremia, particularly which there is associated with urosepsis, then fluid restriction is the first action, and the sensory altered sensorium or seizures with if it's there, then it's again an indication for hemodialysis.
Ijaz, 1 minute. 1 minute.
I am finishing. The surgical management is urinary diversion, and it has been noted in recent in 54 cases published in Journal of Pediatric Urology that if the intervention is done with prior preparation with stable metabolic condition, the complication is low. But if it is done without a hemodialysis, without particular preparation, the mortality is as high as 50%. The commonest mode of surgical intervention is DJ stent placement, but it has got its own merits and demerits. The commonest problem with DJ stenting is trigonal irritation. It is only also a source of septicemia. It causes unit incrustation, forgotten degestion. Dr. Manzoor mentioned in his presentation. Stent migration, stent blockage, and in children sometimes it is not possible to place degestant easily. So in those, so it has its own merit. The other option is placement of percutaneous nephrostomy, but it has its own complications. It's the bleeding, tube dislodgement, septicemia, tube blockage, and general anesthesia. But the plus point with PCN is that in very sick children, it can be done on the bedside, but it requires intervention radiologist services. Overall, the outcome of PCN and DJ stent is almost this same. Once after urinary diversion, the urinary there is clinically acute kidney injury has got 3 phases: oliguria phase, diuretic phase, and recovery phase. In this diuretic phase, if the fluid and electrolyte management is not particularly addressed, they may develop catastrophic complications. So fluid and electrolyte should be meticulously replaced in these children. Luckily, most of these the high output comes from the already present fluid overload. So, and then comes the definitive procedure. I will not touch because this topic has been extensively studied since yesterday, but to name them, the stone can be treated with URS, RIRS. There are so many ways of doing PCNLs, ESWL, laparoscopy, open, and we have so many options. So they need follow-up because Dr. Sajid already mentioned that the children has got a long lifeline and stone recurrence is quite common in these children. So they need lifestyle modification. They should be followed with metabolic workup, metaphylaxis, and I personally ask all my patients to go for ultrasound at least once in a year for a lifetime. In conclusion, acute kidney injury due to calculus injuria is not uncommon, particularly in our setup. Timely diagnosis and management prevents most of these children from chronic kidney disease. Fluid and electrolyte management and dialysis decreases morbidity and mortality. And CT scan is a gold standard imaging modality if it is available. Results of PCN and DGS in urinary diversion is comparable, and stone recurrence is common. Children should be followed with regular ultrasound scan, metabolic workup, and metaphylaxis. Thank you.
Thank you, Jaz. Right. So if there are no questions, no. That's all I know.
Thank you very much. Now I would like to ask Dr. Bashir, Professor of Pediatric Urology in SIUT, presentation of shockwave lithotripsy in pediatric population.
I think there was a pre-poll. Kashif, you wanted to do something before the start of the talk? Kashif. So in this talk, Dr. Kashif has a
just for a
assessment for the.
We have designed this program in a way that all should be interactive. So there are few questions which need to be addressed by audience as well as by the speaker. So there are few questions. You will choose your option, and probably you will get the answer in the presentation, or if not, in question answers. So 1 minute will be.
माजिद साहब सवाल सुन लीजिएगा, आपको जवाब देना है. तो पीछे बैठ के बातें कर भाई.
We should carry on with the presentation first, then we will go for the pool next.
Assalamualaikum. Hello. Assalamualaikum. I will present the presentation on extracorporeal shockwave lithotripsy in children, and I will share my experience. I have no disclosure. As all you know that pediatric urolithiasis is an important global medical problem and multiple treatment options available for renal stone management. It started from open surgery to minimal invasive surgery like mini PCNL, ultra mini PCNL, microperc, ECIRS, RIRS. ESWL still have its own role in the management of stone disease in the era of minimal invasive surgery. In the next 15 minutes, we will discuss the following points. So we will discuss this these points in the next 15 minutes. The first, we will discuss milestone of shockwave lithotripsy. In 1975, shockwave were used on animal model. In 7 December 1980s, the first patient was treated with ESWL, and after 4 years, in 1984, ESWL introduced in stone management of children. There are 3 types of shockwave generator used in these lithotripter, which is electrohydraulic, piezoelectric, and electromagnetic. Electrohydraulic generator was used in human model 1 to human model 4 lithotripter, and nowadays most of the lithotripter have electromagnetic generators. There are 4 generations of lithotripter. The first generation, which is started in human model 1, which is really a very big machine, and the patient was operated under a full-filled water tank. The second generation is also a very big machine. As compared to the first generation. Nowadays, the commonly practice all over the world, we are using the third generation of lithotripter. The machine is more compact. The ultrasound and X-ray is used for focus the stones, and these machines are easily transferable. 4th generation lithotripter, it is sonolith vision lithotripter, the latest development in lithotripter techniques. This machine has dual image system, ultrasound localization system, and the ultrasound focus very precisely to stone and automatically adjust the stones when in moving with respiration, and therefore the very low retreatment rate and required minimal painkiller during the procedures. How the shock wave act on the stone and doing the fragmentations. There is a long list of hypotheses. We will discuss here the few hypotheses. The first is tear and shear force. When the shock wave hit the stone, it acts on the surface like a hammer-like action and resulting a crater-like fragmentation at both ends of the stones. Second hypothesis is spallation. When the shock wave hit the stone and enter inside the stone, and it bursts the stone from inside. Third is the quasi-static skewing techniques. The pressure gradient between circumferential and longitudinal waves, resulting in skewing of the stone, just like a nut cracker which skews the nuts. Cavitations, when the shock wave micro bubbles hit the stone, it produces a micro expulsive erosion at the proximal and distal end of the stone. And the dynamic skewing is a combination of spallation and quasi-static skewing techniques. Now we are discussing now the technical aspect of the ESWL. If you use the good quality gel and apply it between the contact portion of the treatment head and the patient skin, it prevent any air trapping between these two surfaces, and this prevention transmission of acoustic energy loss, and it improve the efficacy of stone disintegrations. The second most important is the energy ramping. If you use the high voltage shock wave, it causes the large fragmentation of the stone, and when these fragments drop down in the ureter, the patients come back with the complaint of pain, fever, pyonephrosis. And second disadvantage of high voltage shock wave, because due to the large fragments, stone broken in the large fragments and is scattered all over the calyceal system, so difficult to focus these individual fragments by ESWL. So always do the low voltage shock wave, start from the very beginning, which causes the vasoconstriction and these of the capillaries, and so therefore the less chances of hematoma, bleeding and renal trauma with low voltage shock wave. And second advantage is to it broken the stone in fine fragments. If you are using the rapid shock wave delivery or increased frequency of shock wave, it generates more continuous micro bubbles on the surface of the stones, and they form a bubble clouds over the surface of the stone, And these bubbles clouds act as a barrier to shock wave energy transmission to the stone, so it reduces the stone fragmentation. Therefore, when we use the slow shock wave delivery pulse, the bubbles hit the stone and it act on the stone, then the second bubble will go and hit the stone. So in this way it facilitates the superior fragmentation. This is a RCT study which shows that a slow shock wave versus rapid shock wave, and the result shows that the high stone free rate in patient who received slow shock wave 90% to 73%. There are other some technical aspect, use of the wide focal zone, use of fluoroscopy for radio opaque stone, real-time ultrasound for radiolucent stone, and also see the real-time fragmentation of the stone by ultrasound, and shallow ventilations in the children's, and told the anesthetist to give the patients a slow ventilation, because in slow ventilation we can hit maximum shock wave hit the stone in slow ventilations. Now, the second point is outcome of ESWL. The outcome of ESWL depend upon the different factors, including stone size, multiplicity, density of stone. These 3 points are inversely proportional with the stone clearance. If the size of stone is bigger, the stone clearance is decreased. If the multiple stones in the kidney and we try to do the ESWL, the stone clearance decreased. Density also inversely proportional to the stone clearance. Stone locations also affect the clearance of the stone. Stone composition, Dr. Sajid told us that in cystine stone, there are lithotriptyle resistance, just like because it is not fragmented by the ESWL. Although uric acid, xanthine stone, ammonium hydrogen urate stone easily fragmented by this lithotriptyle. And the most important point is the operative skill. The anatomy of the pelvic layer system affect the stone clearance. The angle between the long axis of the lower calyx and long axis of the pelvis. If it is acute angle, the stone clearance is low as compared to wide angle. This is our previous published data. In this slide, we see the effect of the stone location on the result of ESWL. In this study, the pelvic stone size and lower calyceal stone size almost equal or comparable, but the clearance rate is low in the lower calyceal stone as compared to the pelvic stone, but not statistically significant. If you see the effect of location and size of stone on required session of ESWL for stone clearance, you can see here the size of a stone in first session 9.6 plus minus 2.3 millimeter stone cleared in first session of ESWL, and the larger size of stone cleared in second session of ESWL. So recently we did a study, and the aim of our study is to evaluate the efficacy and safety of ESWL in the treatment of renal stone in our pediatric population. It is a retrospective study, and we included, it is a 6-year study from 2014 to 2020, and we included all the patients who had renal stone up to the size of 1.5 centimeter and up to the age of 14 years. So the total number of patients was 562, and total renal unit was 603. The male to female ratio 2:1, and the mean age was 5.8 plus minus 3.6. We used in all of these patients SLX F2 machine, which is electromagnetic 3rd generation lithotripter. All of the patients treated under general anesthesia as a daycare procedure. In the result, you can see that the mean size of the stones is 9.6 plus minus 2.6, and it required 1.2 plus minus 0.41 session of ESWL. The clearance rate was 85%. If we divide the stone size in two groups, less than 10 millimeter and between 10 to 15 millimeter, then we found that the mean session of ESWL required more in the 10 to 15 millimeter of stone size, and the clearance rate in the both groups almost equal or comparable and not statistically significant. If you see the effect of stone location on the result of ESWL, you can see here in this study the pelvic stone size is 10 plus minus 2.6, and lower calyceal stone size 8.7 plus minus 2.5, and the stone size in these two groups is statistically significant. But the result stone clearance rate in this both group is comparable and not statistically significant. In our previous study, the stone size was same, but the stone clearance is low in the lower calyceal stone. But in this study, the stone size of the lower calyceal stone is low, so the clearance is good. Now, this slide shows that the effect of the location and size of stone on required session of ESWL for stone clearance. In first session, the stone who cleared in the first session of ESWL has a size of 9.5 plus minus 2.7 millimeter, and the stones who cleared in second session have a larger size, 10 plus minus 2.7 millimeter. The stone clearance versus stone density. When the density is increased, the stone clearance decreased. In the first session, the stone cleared, you can see here, less than or equal to 400 ounce per unit had a 100% clearance, the stone size up to 10 millimeter. This decreased 85 to 75 when the size of stone increased. But in 400 to 700 ounce per unit, the stone size more than 10 have a very less stone clearance as compared to more than 700 stone ounce per unit. It means that some other effects, some other things also affect on the clearance of the stone, just like kidney anatomy and the
1 minute.
Okay. In 5% of patients, we treated ESWL along with DJ stent, in which 3 patients came to us with calculus anuria. We placed the DJ stent, and after normalizations of the renal function, we did ESWL. In 10 patients, after URS lithoclast, stone migrated into the kidney, we placed the DJ and we did the ESWL. In 14 patients, they came with obstructed kidney. We placed the DJ and then we did ESWL. And 1 patient on post-PCNL and post-pyelolithotomy. In complication rate, around 17% of our patients have only fever, pain, hematuria, which were managed conservatively, and they are dropped down into the grade 1 Clavin-Dindo classification. Only 5% of patients developed stent anesthesia, which we managed by DJ stent and PCN and then definitive procedures. Our study, our result is comparable with international results. You can see here, our stone clearance rate was 86%, and here the different study shows the stone clearance 83%, 80 and 83%. Our result is also comparable with European Society of Pediatric Urology guideline. The pelvic stone up to the 20 millimeter of size, primary treatment option is ESWL, and lower calyceal stone less than 10 millimeter is ESWL, and more than 10 millimeter stones is a primary treatment is PCNL. If we see the literatures of different literatures, there is no consensus about the no consensus, and data is not complete in the different papers. So people try to make the nomogram to standardize the standardize the ESWL data, and this is a study. In this study, he used the 2 nomogram, Onel and Doan nomogram, and in this study, they conclude that Dohan nomogram is superior to Onel nomogram. However, more accurate nomogram used and more detailed parameters should be developed. So I conclude that ESWL is a well-established treatment modality for renal stone in the pediatric population. ESWL is the least invasive procedure and may be an excellent option for small stones. However, grayscale still exists in the selection of stones, size, site, complexity of the renal anatomy, technique, evaluation of result, and so on, and required more clarification and consensus. Thank you.
Thank you very much, Dr. Bashir. Anyone would like to ask a question? Sir.
No, I think that every pediatric patient required anesthesia, because when the patient is started to moving to and fro the target, we can lose the target, and the fragmentations and results get then decreased. If the patient is more than 14-15 years, then you can try, but if the patient is smaller age, then it should be done under general anesthesia.
To answer you, Shehzad, you should have anesthesia available, and you may get away without using it in the older children, but certainly not in the younger children. So we're going to move on to the next paper. We can discuss this later on. We are very short of time. Some of
I can give the answer because I did. I give the answer.
Right. Thank you.
In my experience, I did around 600 ESWL, and I did about 600 ESWL in children, and the patients, the small child, even up to the age of 13 and 12, did not tolerate pain. They should require general anesthesia if you want to a good result.
Right. So Shehzad, in Sakkar you can get away with it, in Karachi it's a problem. So we'll move on to the next paper, please. Thank you.
Thank you, Dr. Bashir. Thank you for your nice presentation. Now we'll move to another presentation. I would like to ask Dr. Mustafa, Dr. Ola Mustafa Zafar from Children's Hospital Lahore to present the simultaneous bilateral renal intervention in pediatric urolithiasis. Dr. Mustafa.
So, respected chairs, ladies and gentlemen, assalamu alaikum. First of all, I am thankful to Hyderabad team, especially Dr. Javed and Dr. Kashif for inviting me and for their great hospitality. I have been asked to talk on bilateral simultaneous intervention in children, which is a very much debatable topic, and I would like to share my views and then some literature evidence. So, incidence and prevalence of pediatric urolithiasis is 1 to 3%, and the 13 to 26% have bilateral disease, 13% in endemic and 26% in metabolic disease. So if a child presents with bilateral ureteric or renal stone, what we option have? Either we can go in two separate sessions, one by one, or can we stage procedure minimal on the one side and a definite on the other side, and the third one is bilateral simultaneously in single session. This is what I will talk about in the next couple of minutes. So next question arises, if the patient has bilateral stone disease, and is it mandatory to go simultaneously bilateral, or it's optional? To answer this question, just have a case scenario. This is a 1-year-old boy who presented with anuria for the last 2 days and having creatinine of 2.6 and urea 110. There is a bilateral lower ureteric stone and the one on the other side is upper ureteric stone. So in this patient, we don't have option to leave the one kidney as such. We have to deal the both at the same time. We have option to deal one by one, initially with minimal invasive, then later on we can do either bilateral PCM, or if anesthesia people allow, we can do bilateral digestant, and then after that we can do either bilateral same setting or one by one. Another scenario is, this is a 12-year-old child who had a bilateral disease, stagnant stone on the right side, and there is a huge stone this on the left lower ureter, and the same a large stone on the right lower ureter. This is more clear in this picture. Look, these are two large stones. In this ureteric stone, I'm sure all will be agreed. Even these stone, one stone is not, we cannot get through in one session by URS. These 3 stones. So the option is, if you want to URS, it can be a stage, multiple stage, and you do PCN on one side, or the other option left is open ureteral thrombin bilateral or laparoscopic ureteral thrombin bilateral. And later on you deal with this stagnant stone. So it's case to case varied depending on the case scenario, patient clinical situation, and underlying stone disease. But what about this? Again, the same. You start thinking, what ought to be clear in this one session or not? It will be difficult to clear in one session. So this was about the many times you don't have option to leave the one kidney. You have to go bilaterally in single session in emergency setting. Later on, you can plan it. But in simple cases like this is a 10-year-old boy who was mild symptomatic, otherwise fit, normal RFTs, and in such patient, you have a liberty to choose either you go one side, single session one by one, or you want to go bilateral same session. But the question here arises, why you want to go bilateral simultaneously? The idea behind going bilateral simultaneously is you want to reduce the cost of procedure. And how it can be reduced? So start from the lab investigation, CT, IVP, then laboratory investigation, and then anesthesia investigation. If you do this in 2 settings, after 1 month or 2 months, you have to repeat most of the investigation. That will add the cost. And then operating room cost, then medicine cost, that if you do in a single session, that cost will be reduced. Then single cystoscopy, reduce cystoscopy, one time, put ureteric on the both sides, then decide you can do bilateral or not. Then single anesthesia team and single anesthesia, second anesthesia can be avoided. Less radiation exposure, especially in children, rather going into second session. Then hospital stay, single hospital stay rather second time for second procedure, single surgical stress to the surgeon as well as to the patient, and then early return. The convalescent period of 2 procedure, 2 to 3 weeks are every time, and then patient will go to normal life. That actually reduce at the cost expense of the money, and then being absent from the school or a worker to the work, then that also is a short labor cost. Then follow visit will increase, psychological stress, patient satisfaction, and the most important is the physician or surgeon fee. Patient has to pay once for both disease, but at the cost of the surgeon disinterest. Surgeon will get one fee rather than going operating on the both side. The concern of surgeon by going bilateral are there excessive bleeding, if you intervene in the both systems simultaneously, the risk of acute kidney injury, respiratory distress due to fluid overload, prolonged operative time may lead to complication, hypothermia in children, which is also very important and difficult to manage, and then prolonged hospital stay. If the lung surgery, the hospital may be prolonged, and the surgery fee, which I have discussed earlier. So, if you look at the evidence from the literature, people are doing bilateral simultaneously, but whenever we do a procedure, we have to see how much is effectiveness and outcome of feasibility. This was the largest review of 20 years last, starting from I think 1998 to 2018. In 20 years, the bilateral surgery simultaneously were done with review in this paper, in which 2,000 patients were operated, and there are 300 articles were evaluated. The mean operative time with bilateral simultaneously was 150. Stone-free rate was more than 90%. Hospital stay and complication was 33%. The bilateral simultaneous group, their complication was slightly higher, which was significant, but these complications was grade 1 and 2 only. So it was acceptable. So it means, if after looking at the literature, we can proceed bilaterally simultaneously, but not in all the cases. But what is the criteria? That your operating time, total operating time should not be more than 180 minutes. That means if you have completed the one side procedure in 1 hour or 60 minutes or 70 minutes, then you can proceed on the other side. If you have spent 2 hours on one side, then it's not justified to go and start another one. The second is the hemoglobin drops at the end of one side procedure. If hemoglobin drop is more than 3 grams, this also preclude your proceeding. Then pH drop, patient has hyponatremia, hypotension, and saturation drop in the first procedure. These are one or more factor preclude or inhibit the proceeding to the next side. Simple cases like this can be done bilaterally simultaneously, keeping that criteria in mind. There are few contraindications, like the stone size is more than, surface area is more than 1,000 millimeter square, complex calcium anatomy, AS score, hemoglobin is less than 12, and patient refusal. In these conditions, you should not try bilateral simultaneously. The other scenario is the patient has the partial stagnant stone on the one side and the medium sized stone on the other side. In this patient, you have option of either you do PCN on one side and ESW on the other side, but in children, as has been discussed, children will need ESW, will need CZF or ESWL. The other option is bilateral simultaneous PCNL or PCNL on one side and the RERs on the other side. So this is another way of bilateral simultaneous intervention. Now come to the RERs, or flexible uterus, which is now trendy nowadays, and the name is natural orifice transluminal surgery, which is NOTES, and the node surgeon or proponent of RERs are this. Basically, RERs was started in adult in certain situations like patient who have coagulopathy, abnormal renal anatomy like HUC kidney, ectopic kidney, obesity, solitary kidney, pregnancy, and ESW failure. The proponent of RERs or node surgeons says that PCNL is actually not, it's not a minimal invasive, it's an invasive procedure. RERs is minimal invasive. But in my view, actually basically PCNL and RERs are not comparable, because this is PCNL is for major large burden stone, and this is for small and the medium sized stone, but these two are not comparable actually. If you want to compare the RERs, it's compared with ESWL or microperc. However, the other the point raised by the node surgeon is when you do PCNL, there is in especially multiple tract, there is evidence of renal damage. Small size kidney, there's small space to manipulate while doing PCNL, and excessive bleeding, adjacent organ injury is high in PCNL as compared to RERs. In spite of that, there are, people are doing RERs in children, but there are some concern in children, especially For RESL, the child will need multiple sessions, especially to put stent first under GA, to dilate the ureter, then do RAS, and at the end of RAS, many patients again will need the stent. So 2 or 3 procedures at least he will need. Then keeping the ureteric access sheath in ureter for 1 hour or 2 hours may lead to ischemia, can lead to ureter lateral and stricture formation, perforation, avulsion, and this is the most important. If a child ureter, the child of 10 years, 8 years, or 6 years, you dilate the ureter 10 FR or 11 FR access sheath, in future, that will lead to incompetent vesico-ureter reflux, and study has to come how much this reflux comes. So we are waiting, people are doing RES, but in future we'll tell how much these VUJ become incompetent. And while doing RES, the laser is used, which produce high energy, and how kidney is damaged, how much is damaged while doing RES in children. This will also I think will be evident in time, after some time with studies. So these are a few studies where people are doing RES in children. They are unilateral, and the unilateral RES in children, they claim they are good results, although the size of the stone is smaller. Mean is 7 to 24 millimeter, operative times 72 to 196 minutes, and stone free rate is 96 to 100%, which is almost equal to PCNL. Short hospital stay and complication yet has to be reported. So, should we go for bilateral PCNL in children, bilateral RES in children? Yet to answer, there's no answer in the literature, because only few case reports are 2-3 publications which have a patient of 10, 15, 20. There's no too much large publications. Bilateral URS simultaneously, RES can be done, how much safe is. So this is, I think, still not recommended, and no guideline. However, it depends on the patient condition and the surgeon's own expertise and ability of the gadgets. So whatever we do, bilateral, either bilateral simultaneous PCNL, bilateral simultaneous RES, or RES one side and PCNL on the other side, there are predictor of complications. Most important is the anesthesia time, operative time, core body temperature, hypotension, and hemoglobin drop. If any of this factor happen during the first procedure, then I think better to stop, because patient safety is the first one. So how to decide? There's a second last slide. How to decide should we go bilateral or single session? The idea is you consult the patient. Okay, we have planned to do bilateral simultaneously, but we will decide at the end of first session on the one side. You do cystoscopy and put ureteric catheter on the both side, and then make the position. At the end of one side, you assess by that parameter which I have discussed earlier. If you have completed the first side in reasonable time, there is no blood loss, no hypertension, no major complication, and the most important is if the anesthesia team is agreed, then you proceed on. So, to conclude, the outcome of bilateral simultaneous intervention, although are almost equal to stage procedure, with advantage of reduced cost, but not all patients are suitable for it. And careful patient selection and optimization important, and this is most important. The surgeon should be experienced. At least a person who has done 50 or 70 PCNL or RES, then he should try this. This is not for the beginner. Thank you very much.
Thank you, Mushtaba, and thank you for giving us the guideline and the difference between a bold surgeon and a stupid surgeon. So if we'll allow one question. Okay. Ji Shahzad sir. Use the mic, please. There's one at the center.
We know you are doing very hard work in the house. My question is, you said that PCNL is expensive, is not
not my opinion. I quoted the opinion of no surgeon. The people who are doing RIRS, they said the PCNL is invasive and RIRS is not invasive.
Especially done by.
Because the idea behind what they want to say, because there is incision and tract dilatation, incision, then tract dilatation, then the anti in the kidney, but in RIRS, everything is through the natural orifice. That's why they'll claim.
My second just comment.
Yes, yes.
Is that you mentioned the criteria of doing bilateral surgery, but can you add into that criteria that the surgeon should be very proficient in PCNL and RIRS before he or she is even thinking about the bilateral surgery? Because if the surgeon is just doing this for the adventure purpose, then he is in danger of the life of the patient.
I think my last statement was this: the experienced surgeon.
So Shahzad, I did explain the difference between a bold and a stupid surgeon. So thank you very much.
Thank you. Thank you.
Now the next session is on renal stones, that is the interactive one. May I request Professor Malik Hussain Jalbani, Professor Liaquat Ali, Dr. Khalid Hussain and Dr. Zakir Hussain Rashwar to please come on the stage and moderate the session.
Assalamu alaikum. First speaker of the session is Dr. Imran Jalbani. He will talk about stone breakers or vaporizers, feasibility, cost and evidence-based outcome. Dr. Imran.
Thank you very much. I'm extremely thankful to Professor Javed and Dr. Kashif. Kashif has a very nice brain that he keeps on bringing the new ideas and topics for the discussion. So that as you can see, the talk of my talk was basically Kashif called me and said that can you talk on this? I said yes. So these are the key points which I'll be touching on: stone breakers versus vaporizers, factors to consider, and the treatment goals. As we all know that lithotripsy, in situ lithotripsy started with the pneumatic lithoclast, then we got an ultrasound, and now it's era of laser, and especially holmium laser has been widely established as a commodity to use in stones. And this chart shows the mechanism of actions for junior residents of each modality. So this was an in vivo study, in vitro study, and that shows that there is a significant difference between all three modalities with the pneumatic lithoclast and ultrasound if you combine both the modalities in terms of a total time. What about laser? We all know that laser does not operate at a one setting. It has to be setting which you desire for. If you're desiring for the dusting, you have a different setting that is low energy, high frequency versus stone fragmentation and popcorning. It's a high energy and low frequency. For a junior faculty or residents, if you're planning for the dusting, it's basically you're touching the laser fiber with the stones that will cause dusting. Once you're done with the dusting, at the end of the procedure, like RIRS, you will have a fewer fragments now. Now you can change the setting, and this will be non-contact laser, and you'll slightly increase the energy with the low frequency, so you can pulverize the rest of the fragments. Even though this is older data, a decade ago, but you can see there's a significant difference between the cost of ultrasound versus laser, $100 versus $300 for holmium YAG laser for each patient. Overall cost of holmium YAG laser is still is in a big thing. That's $80,000 nowadays, 100-watt laser, and that's a high undertaking for a country like Pakistan. But most of the centers in Pakistan, they are having a laser as a device for stone fragmentation. So we all know that the kidney stones can form in the kidney, ureter, bladder, or even in the urethra if there's an anatomical abnormality. So you need to take care of these stones with respect to size and available commodities what you have. URS, it may be rigid URS, semi-rigid versus flexi URS, and in terms of a bladder stone, so I'll be talking about these all things in coming slides. So what about renal stones? We know that renal stones more than 1.5 centimeter or above are taken care of by PCNL. But in PCNL, what is the best fragmentation device? What you have is pneumatic lithoclast, a combination of a lithoclast with ultrasound or laser. So I was searching for the randomized trials, and I could get few, so that we can say that which one modality is effective, and it's more in terms of stone-free rate and decreased complications. This was published in 2021. A randomized trial, comparative study basically comprising of almost 120 patients in each group. That concluded basically the comparison was between pneumatic lithoclast and the combination of ultrasound basically. But so the ultrasound showed in this study superiority over the time. In terms of a short time, you can get a more stone clearance with a similar complication rate. This is meta-analysis which was published in January 21 in, 9 randomized trials, 6 cohort studies, and the similar conclusion came out that at 1 month stone-free rate with a combination of ultrasound over lithoclast is better in terms of getting stone-free rate and lesser complications. This is a randomized trial of staghorn stones comparing between the holmium laser versus ultrasound. This was published in BJUI. This was from Mansoura group by Professor Nahaz, and we can see that there's a slightly increased time if you're using laser for PCNL for stone fragmentation versus ultrasound. So ultrasound, you can get same job done with a lesser time and lesser complication rate, but hemoglobin drop was more in ultrasound versus laser. Again, level 1A evidence that suggests that ultrasound is more effective in clearing the stones and having a decreased stone-free rates, have increased stone-free rates. So non-laser breaker device like ultrasound lithoclast are more effective in terms of stone-free rate and complications. In laser group, it was interesting to note that they have a slightly higher post-operative fever. What could be the logic of behind that? I really don't know, but this was concluded on level 1 evidence and the meta-analysis. So if you look at the EAU guidelines currently, that suggests that currently pneumatic lithoclast and ultrasound are a combination of two are most commonly used devices for PCNL. Holmium laser is increasing over the time, especially once we have miniaturized the PCNL to mini, micro and ultra mini PCNL, which can be done by laser. So coming up to the ureteric stones, what about ureteric stones? We all know that ureter is divided into 3 parts, and the stones are divided in proximal, distal and middle ureter. Problem with the proximal ureteric stone is a retropulsion rate, which is as high as 30% if you're using pneumatic lithoclast. So this is the paper from Kidney Center. They showed that the pneumatic lithoclast versus laser having the same time efficacy. There's no difference in operating time if you're doing a laser versus pneumatic lithoclast or ultrasound. Again, a paper from Egypt. Retropulsion rate in laser was as low as below 7% versus 27% in lithoclast group. So that's a major concern when you're dealing with the proximal ureteric stones. So laser is much more superior in dealing with proximal ureteric stone. Either you are using semi-rigid scope or flexi URS. Again, this is the paper from Egypt, but published in Arab Journal of Urology, and you can see that the cost of laser procedure is double the cost of normal URS. For example, it's 3,000 Egyptian pounds versus 6,000 Egyptian pounds in the laser group. So there's a huge difference between the two procedures and the cost of equipment. So what does guidelines say? That most effective lithotripsy system for flexi URS is again laser. You can't do flexi URS with obviously rigid instruments, and recommendation is to use URS flexi laser to do a URS. Even with a semi-rigid scope, if you do a laser in proximal ureteric stones, you will have much more higher stone-free rate, which is around 93–94% versus 70% in using instruments like pneumatic lithoclast. So is holmium YAG laser is the only option, or we have something else evolving as well? As per current literature, you can very well see from the slides that thulium laser is now coming into part as well. And this is going to be next standard of care in a few years maybe. The reason behind that, it is a much lighter weight machine. It does not need a cooling system, which is air cooling system. And it can fragment the dust stone in a much smaller time than the holmium laser. So what about bladder stones? I could not get enough literature for laser to be used in bladder stones, but we can see that using an ultrasound in nephroscopy and nephroscope ultrasonic lithotripsy, I mean cystolitholipexy, is much better than pneumatic lithoclast, because it has decreased chances of a bleeding and more clearance. So whenever we as a clinician decide about procedure for managing a urolithiasis patient, obviously we have taken a lot of things into consideration. One, the equipment or modality you're using should have better stone clearance in one go, time effective, it should be minimal invasive, as there has been enough discussion regarding minimal invasive versus open surgeries. And there should not be, I think, more ancillary procedures. If you can avoid ancillary procedure, that can decrease the morbidity as well as the cost. And obviously the cost has its implication to play, especially in a country like Pakistan. So the current cost for holmium laser is almost $80,000. each fiber costs around $250 to $1,000. And obviously there is a degradation of a fiber with the procedures. So you will need a replacement for that. And Flexi URS, either it's a single use or multi-use, it costs significant. So if you're using a reusable Flexi URS, then it can save the cost, but still there's a significant cost, like a 3.5 or 4 million cost for Flexi URS. So the take-home message from this presentation, I would say that ultrasound is more effective in dealing with the stones for PCNL. In terms of time efficacy, it can get good stone-free rates as well. Laser is more effective and a better stone-free rate in proximal ureteric stones if you're using. Retropulsion rate is much less with the laser versus pneumatic lithoclass or ultrasound. Laser is almost compulsory equipment for the modern day urology. You can't say no to this statement. And what next? I think thulium is going to replace holmium in coming years. Thank you very much.
House is open. You can ask 1 or 2 questions to save the time, please.
I totally agree with him, but my personal experience is that if you come across to a bigger stone in the bladder, you can divide it into 2 by using the laser, and then you can proceed with your lithotripsy rather than go by inserting the PCNL sheath and this and that.
Dr. Shehzad, I totally agree that on the personal experience you can do a lot of tricks which you're mentioning, which is important for the clinical management of the patient. Yes.
Yeah, this is the another fact that we usually quote the literature from the West and try to apply in the East, and we do not honor our own experience. Our own experience are sometimes they are much costlier than the Western their recommendations. So whatever our experiences are, we should also propagate them.
Agreed.
Thank you, Shehzad.
I have a compliment for you. Thank you, Imran. You have presented your topic very short notice. 2 days ago, we have informed Imran because this topic was presented by our one of senior. He is not able to come because of some unavoidable reasons. Bundle of thanks.
Thank you, Dr. Javed.
So, I think we should. Have you query? Yeah.
I don't have any question.
Okay.
I have only comments. In the meantime, we can go on. I think my comment is very simple. That in my experience, is a level 4 evidence, and if you are comparing East with the West, get your experiences published so that we have a level 1 evidence.
That's really correct. That we are not publishing our work. Another point is that the major the journals are not publishing our data as well. Always they refuse to publish our data, most of the time. So as we are running short of the time, so our next speaker is our guest from the Nepal, Professor Mahesh Adhikari. His topic is the role of ESWL for the renal stones in the era of the minimal invasive gadgets. Professor Mahesh Adhikari.
Good morning, everyone. Respected chairpersons, faculties, and all delegates. First of all, I'd like to thank the Hyderabad Urology Society for inviting me to be a part of this auspicious meeting in Hyderabad. So I've been given a topic of on ESWL, the role of ESWL in the era of minimal invasive gadgets. I'm not a proponent of ESWL, but I would like to justify ESWL in this era. So very warm greetings from Nepal. This one is it. So there are different approaches for managing renal calculus. Beside open surgery and laparoscopic surgery, ESWL as a mean of minimally invasive surgery was introduced before PCNL and RRS. Okay, and then shock lithotripsy actually was considered as a very successful treatment in the past, but with the introduction of PCNL and RRS, the role has been, questioned for many years. So what is an ideal treatment for urinary stones? It's a $1 million question. The least invasive, minimal morbidity, minimal or no hospital stay, high stone-free rate, should be cheaper, especially in our context, easy to perform and replicate, and minimal equipment requirement. So if you see the trend of stone management over the years, this is paper published quite long back, but still you can see there's already a trend has started. So if you see the PCNL is a constant over the years, the URS has coming up, whereas the ESWL was already going down. And if you see the other paper, see the URS is climbing up, and the ESWL is almost dying off, almost to zero, and the PCNL is a constant phenomena. If you see this slide, the red one represents the ESWL being performed by the non-urologist, especially in our part of the world, So ESWL machine is kept in a center, and then people they actually refer patient for ESWL, and also being done by non-urologist also. Even so, some of the ESWL is referred by the pharmacist. Some of them are referred by the physicians. So it's being actually done more by the non-urologist or non-endourologist. So there has been debate in AUA, UAA, so many big conferences. They have pointed out that ESWL, since its introduction in the 80s, the stone-free rate in ESWL is same as 30 years back. So it's not evolving. So there's always a question that the endourology may be replacing ESWL. Similarly, Glenn Pleminger, one of the player of the endourology, also mentioned the same thing, and Ralph Clayman also said the ESWL used to be almost 70% stone management, and it's decreasing to 30%, even less than that these days. So there has been a comparison between ESWL and other modalities like RIRS, PCNL, and they've all said that ESWL definitely has a lower stone-free rate and the lower, higher ancillary procedures needed to clear the stones. Similarly, other studies also mention the same thing, that ESWL has a lower stone-free rate and the needed more ancillary procedures. These are all big meta-analysis comparing many RCTs, and they say you can see the area under the curve in ESWL is very low in terms of stone-free rate and the ancillary procedures. Whereas it may be good in terms of transfusions, fever, operative time, hospital stay, fluoroscopic time, and hemoglobin decrease. But the most important thing is stone-free rate and ancillary procedures are significantly lower than the other procedures. So the other paper also mentioned that the retreatment is highest in ESWL. So with these all objective findings, can we conclude that ESWL is on a deathbed? So this is a very important question nowadays, because the procedure which used to be a very common and used to be very effective in the past is suddenly going out of favor in most of the urology centers. What is dragging shockwave lithotripsy to its deathbed is as mentioned in the papers, the lowest stone free rate, need for auxiliary procedures, and prediction of the fragmentation is difficult, especially in the hard stones. So for this thing, are urologists responsible for this or not? Because we are not actually counseling the patients about the pros and cons. We are actually imposing the patients about our newer procedures. We say we are trained in the urology. We want to play with the tools so much that we have forgotten one of the best procedures in the past. I would like to share one. I myself is a stone patient. So I had 9 mm stones in the upper ureter, and then I wanted to get it shockwave, because I didn't want myself to be, catheterized, uteroscopy introduced inside. So I wanted to do a ESWL, search for the ESWL machine in the valley, in the capital. There were 6, 7 good ESWL machines working, but that time I actually needed, none of that were functional, because they all said that it is out of practice. Nobody is using. And the ESWL machine in our center was also out of function. So I called my biomechanical engineer, then fixed the machine over the night and then did the ESWL. Luckily, 100% clearance was there. So I want to raise a question in the platform that if any of us has small stones in the kidney, we'll definitely go for ESWL rather than going for all invasive, instrumentation inside our body. So I think we are lacking the shared decision making with the patient. We want to impose our whatever available in our center to the patient, and then that's why ESWL is going out of favor. So with the COVID-19, it is an important landmark for everyone. So we thought that with the COVID, people are afraid of anesthesia and all. The ESWL will rise again, but it didn't happen actually. So there was no effect of the COVID-19 in the ESWL procedure. So when you focus on problems, you get more problems. But if you focus on possibilities, so I'm not a proponent, but I have a soft current for ESWL. That's why. So there are guidelines. Although they treat less number of stones than we do, but we follow these guidelines. So these guidelines, although they have a space for shockwave lithotripsy for renal stones, lower pole, non-lower pole stones, they have for sizes, and for uterine stones also, even the EUA, AUA also, they have a space for shockwave lithotripsy in all areas of the kidneys and the ureter. So the ESWL itself, this part of the presentation has been made easy by my previous speaker, so I don't want to go in this detail. So why shockwave lithotripsy could still be an option? Because it has less morbidity, outdoor procedures, no need for anesthesia, hospital admissions, less expensive for the patient, and good result in selected group of patients. So who are the selected group of patients that we need to actually classify? So there are different systems to classify who are the selected group of patients. There are different ways of selecting. One is triple D scoring, that is, we call it dimension, distance, and the density of the stones. So depending on that is a scoring system. If you have 3 scores, that means if the dimension is less than, they have mentioned dimension, density, and if it is favorable, then the outcome is almost 96% success. So you have to select patient according to this, and there's a
this 3D system is again challenged by another 4D systems. They've also included locations, whether it is lower pole stones or not. So that way also you can actually classify the patients whether it's favorable for ESW or not. So this is quadruple D systems, and the other system they have come up with the even more variables. They have S3 HUC wave that includes 6 skin to stone distance, size of the stone, Huntsman unit, whether you have a colic pain or not, or is the stone in the kidney or ureter. So there's a scoring system here, depending upon whether it's a male or female, colic absent or not, kidney, upper ureter, lower ureter. They have a special number for each of these variables, and the higher the variable, total number, the ESW failure rate is high. So you can actually classify patient according to this, and then actually get a good outcome out of the ESWL in this selected group of patients. So another important aspects of sarcolepsy, we all do PCNLs, RIRS, and invariably for some of the cases the residual fragments are there. And then unless and until you clear the stones, patients are not happy. And sarcolepsy has become a very a kind of modality to clear the stone residual fragments, and it has been seen that it is more effective in the fragments than the primary stone of the same size. So it's a good armamentarium to rescue us for the residual fragments. So this is a hospital I am working. It's a 750 bedded multi-speciality hospital, and then the ESW is done by one of the graduates from SIUT. I'm very happy that this guy are very trained in sarcolepsy, and the other guy also is FCPS urology. Both are FCPS urology, and they are trained in SIUT. So I'm very happy to have them, because in our center this ESW is being normally done by the doctors, not the technicians. And we use a patient control anesthesia PCA in each patient. So since I am proponing for the ESWL, there are ways to maximize the efficacy of the ESWL by using medicines like alpha blocker, diuretics, analgesics. If you see the parameters on the right side, the alpha blockers improves stone-free rate by obviously dilating the lower ureter, diuretics, analgesics, potassium citrate, and microbubbles. These days they come up with microbubbles, that is, you inject microbubbles through the ureteric catheter every 90 seconds, and that has shown to improve the outcome of ESWLs. And the last thing is obviously mechanical percussion, inversion, and diuretics also helps to clear the lower pole stones. In terms of radiation exposure, if you compare, it's better than the other procedures, PCNLs and even RIRS. You are involving more of the radiation in those procedures. So in that term also, ESWL is better than the RIRS and the PCNLs. So if the procedure is really dying, how can we reinvent this? There are ways. Nowadays they are coming up with shockwave lithotripsy, using lithotripsy using the ultrasound waves. So this burst wave lithotripsy is a high frequency ultrasound. It will actually localize and can also fragment the stones, and it emits a high ultrasonic waves that breaks the stones. And they have published a paper using in 19 humans, and they've concluded that there's a 90% combination of the stones. So it's a quite promising tool in the future, but the studies are still to come, and then it's still not practiced in. See, the other thing is histotripsy. Histotripsy is actually something like burst wave lithotripsy, ultrasonic lithotripsy, originally designed to fractionate tissue structures through extremely precise liquefaction. It's basically a kind of what you do in HIFU. So it's like a HIFU, and then it has been actually, the paper was published in 2011, but somehow it didn't work, the histotripsy. But these days they are coming up with new changes in this histotripsy, and then it could be a future for socket lithotripsy. So how to improve the effectiveness of ESWL is definitely improvements in locations. There are so many navigation systems coming up, and there are radiometrics. The radiologists are involved in localizing and fragmenting the stones. Monitoring stone fixation is very important. Implementation of different focal size with new acoustic lenses. And coupling control is very important, avoiding micro bubbles, and the low-cost device for different applications are needed. So finally, the key points is appropriate patient selection is key to the success of socket lithotripsy. By using those maneuvers, the slow rate ramping of energy, appropriate coupling, and frequent imagings are important for successful socket lithotripsy. Burst wave and histotripsy could be a future in the future of socket lithotripsy, and infused microbubbles technique may be the future to adjunct improve efficiency and safety of the lithotripsy technology. So finally, I like to conclude that ESWL is actually very least invasive procedure with a quite moderate outcome, and could be an option for the selected group of patients. And the future of socket lithotripsy, it depends on the reinvention of socket lithotripsy and the improvement of techniques. Thank you very much.
Thank you very much, Professor Mahesh, for concluding your talk within the specified time. Thank you so much, sir. So if there is any question,
yes,
we can have. Yes,
I have a suggestion. If you add to in your conclusion that the payment made to the surgeon will be equal for lithotripsy versus RIRS, the lithotripsy will not die.
Thank you.
Yes, Dr. Sabdar, please.
Professor Adhikari, I have one question. You presented one study and you gave a reference that area under the curve was very low. To my knowledge, area under the curve is for diagnostic tests and not for the treatment. I think there must be some coordination between a urologist and the statistician.
This is sucra value surface under the curve. This is not area under the AUR. This surface sucra value surface
because
under the curve.
That's fine then.
Okay.
So,
Assalamu alaikum, sir. Me, Dr. Gadan Farali. Sir, thank you very much for coming Hyderabad. Sir, my question is that what is your thinking about the pre-stenting before ESWL? And what is the impact of pre-stenting for the clearance after for the ESWL?
My personal opinion is, I mean, in literature, actually stenting is a negative value, negative for ESW. It decreases the stone-free rate if you use the stenting. But if you think that, I mean, if you are stenting, why you go for socket lithotripsy? Primarily, if you are planning to do a shockwave because to minimize the invasiveness. So if you are doing stenting, already stenting, you can do other procedures, you know. So my thinking is like that. Otherwise, scientifically seeing, the success rate of ESW is less when you have a stent in place.
Thank you, sir.
Okay, sir. One compliment and one comment on Professor Adhikari. Definitely, still there is a use of the ESWL. as you have mentioned yourself that when you was having a stone in the upper ureter, you find that where is the ESWL. So still definitely there is a role of the ESWL, but in the selective patients. And I just remember the slide of Professor Manzoor Hussain, that when the anti-stone drops will be banned, then I think, and awareness regarding the patient, then ESWL again will emerge. Otherwise, ESWL definitely will die out. Thank you very much. Thanks. The next topic is from our another guest, avoiding the complications during PCNL. From Sri Lanka, Dr. Srinath from Srinath Chandrasekhar. Thank you, sir. Srinath sir, you have come from the Sri Lanka, where the things are similar like Pakistan. So again, we are welcome. Professor Javed, Chief Organizer and Head of the Department of the Faculty, my good friend Ahmad and all President of the House and all senior colleagues and friends. It's a great honor to be here. This is my fourth visit in Pakistan, but the first time in Hyderabad. Hospitality, and I thank all of you for inviting me and for your kindness in looking after all of us. So I come from, as the chairperson said, a very similar background in more than one way. I think we have similar genes, we have similar medical problems. Now added to the list, we have similar economic problems. So I think what we have to say here is very common, the lessons we learn are common. So in that context, I think managing the not so infrequent complications of PCNL also brings that much relevance to this forum. So
Before I crack on with my presentation, I'm going to time myself so that I won't exceed time. So the healthcare system is very similar to that in Pakistan. We have all emulated the British NHS to some extent. We have the public health system which runs free of charge. It is there in every part of the country. We have access to a specialist surgeon within 1 or 2 hours of driving time, in any corner of the country. Doctors are allowed to work both in the state as well as the private sector. We are 22 million, just about the size of Karachi in population, but only 45 urologists, so we sleep very little. So I put here the glossy photographs. These are the better hospitals we have. But like in Pakistan, there is some degree of disparity where the state system faces many challenges. So PCNL, as you know, with advancing technology, better understanding of pathophysiology and particularly the anatomy, and increasing expertise of those who perform this operation, PCNL has become a very Asian operation. And also the morbidity and the occasional mortality following this procedure has seen a significant downward trend. Despite that, there are numerous complications that we encounter with this procedure, especially in tropical countries where the stone burden is very high and patients present late, of which, as you see in this list, I'm not going to read out every bit because you can see in the presentation, infection, bleeding, and visceral perforation are some of the commoner problems. Mortality, fortunately, in this often elective procedure or always elective procedure is very rare, and it continues to come down from the few reports that we occasionally see. So let me address some of these key issues one at a time. As you know, sepsis is not uncommon. 1 in 10 patients following PCNL are reported to have some evidence of infection, either with a febrile episode, a positive urine culture, or other features of inflammation or infection, of which about 10 to 40%, a varying degree of people may develop sepsis. So again, sepsis, which is the very serious complication, is fairly infrequent, and it is characterized by features of systemic inflammation, as you see in the slide. And people with following PCNL may have these features to a varying degree, and you need a high degree of suspicion to identify and treat these conditions. So these are some of the widely quoted risk factors, and I'm quoting, I know there are bigger lists, but I'm quoting from the widely accepted literature with multi-center studies. Positive preoperative cultures have shown significant correlation with postoperative infection. Larger stones, as well as long operating times, especially when it exceeds an hour, the use of multiple tracks, blood transfusions, which once again means that the procedure has become complicated, have shown strong correlation of significance with sepsis. The preoperative state of hydronephrosis and diabetes, which indicates immunocompromise, may also contribute to this complication of sepsis, and you need to watch out for these problems if you want to prevent. I think complications in PCNL must be prevented to the greatest extent possible, because it is an elective operation and you do not want to have an issue after surgery in elective surgery. So let's look at prevention. Numerous studies have shown that prophylactic antibiotics, even despite negative cultures, have reduced the incidence. So use antibiotics. I always use antibiotics with PCNL, and especially if the patient has had previous sepsis or positive cultures, then you should convert your treatment regime to a therapeutic course of broad spectrum antibiotics, and your cultures, if you pick any positive culture before surgery, should be negative with antibiotic therapy prior to surgery, and your inflammatory markers should be reasonably low. You'd note that in many patients that you handle like this, you are an experienced audience, inflammatory markers do not come to baseline, but it should be reasonably low and stable with negative cultures before you embark on surgery. If there is obstruction, we need to drain it, and we should not go and operate on people who have obstructive systems with any evidence of inflammation, whether it be inflammatory markers or positive cultures, because these carry higher risks of sepsis during and after surgery. And of course, early diagnosis with a high index of suspicion are key to avoiding these problems. A key point, Professor Rana is here, we have been talking about this over and over again. Please do not do heroic tubeless surgery if there is any suspicion or indication of potential sepsis in a patient. Now this is the starting point of big disasters. You don't have to do, I'm a key proponent of tubeless PCNL, majority are like that, but I am very careful in choosing my patients, and if there's the slightest hint that this patient might end up with sepsis, you should then avoid tubeless surgery, and these patients should be adequately drained. So now this is the more challenging situation when you end up with sepsis in a low risk patients who do not have these problems. So this is when the surgery has sometimes converted a low risk situation into a high risk situation. So again, the experienced surgeon needs to watch this. So if you have a patient who's had no major risks, in other words a low risk patient who develops infection or sepsis following surgery, I'm not talking about the asymptomatic positive culture, which is not infrequent, but any evidence of sepsis, look for problems. Maybe we have created a new problem which is now giving rise to sepsis. So often it's a clot that obstructs the ureter, a small fragment of stone or debris, or occult sepsis. Sometimes stones can be infected, which has now disseminated and giving rise to this situation. Extravasation is the other thing. If there are collections, if there is perforation of the kidney or an inadvertent perforation of a surrounding organ, especially the colon or bowel, well, these can be problems that give rise to postoperative sepsis. I'll talk to you about this in a moment. I think we perforate more bowel than we know. That's because most of these things go unnoticed with just a postoperative febrile reaction. So you need to watch out. And of course, when you do high volume in busy centers like we all work, we always need to keep in mind the possibility of breach of sterility. So sometimes there's a problem in the sterile chain and you need to do your audits, and if this is happening more frequently, then you need to investigate and correct your problems. So now I come to the next topic, which is bleeding, again discussed widely during the last 2 days. So I'm going to just touch upon the highlights according to my experience and the knowledge through reading. Minor bleeding we know is common following PCNL, and we don't need to discuss that. It settles with good hydration, if necessary things like tranexamic and rest, but significant bleeding is what we need to watch out for. The reported incidence is variable, and it touches 7 to 8%, sometimes higher, sometimes lower, but we seem to be over-transfusing our patients because the global reports or the reports across the world of transfusion rate from 5 to 18%. So maybe we are over-transfusing our patients with a degree of, some degree of bleeding, and this is reflected in some of the widely quoted statistics from accepted meta-analysis. So the trigger factors of bleeding during PCNL can come during all stages of the procedure. So that's I've listed out during puncture, during dilatation, and during stone fragmentation as well as instrumentation. So this is a problem that we can largely avoid by being more conscious of what we do and understanding our anatomy of the treatment. PCNL at best is a blind operation. We understand the anatomy, we go through ultrasound or contrast studies to look at the calyceal system, but just outside what we see is renal parenchyma, which is highly perfused. I do not need to explain this anatomy to you because you all know what I'm talking about. The calyces are, around the calyces, we have a rich plexus of arterial blood vessels. And if one goes and perforates these by a suboptimal puncture, by means of going at a different angle or going to medial or sometimes overshooting your needle into the more central parts as seen with the diagram B and C, then the risk of bleeding with PCNL is higher. So as we Asians have now modified this operation into a much safer procedure, this technique has come largely from the South Asian subcontinent, the infundibular puncture coming from laterally, which goes through the least vascular, through the Broddel's plane into the infundibulum of the calyx, avoids these blood vessels to a great extent, thereby minimizing puncture. I think these are some of the key advances in PCNL that has rendered it to be a much safer procedure. Now, let us look at the adversities of a suboptimal puncture, again discussed widely yesterday. If we go through an acute angle into the calyx without going in line with the calyx with an infundibular puncture, what happens often, especially with large bore punctures, about the bore we will talk about in the next few slides, we are compelled to torque our track. We are compelled to bend our scope, bend our track, and as you see in this diagram here, which was drawn by one of my assistants, these are all my own diagrams, you tend to tear the kidney. So this is a starting point of a big disaster. You go and puncture the calyceal necks, you puncture the arterioles around the calyceal necks, or you go and torque the kidney and you tear your parenchyma. Well, that's the starting point of a big problem which can end in unnecessary complications. So please be mindful. We are all mindful of our calyceal anatomy now. Do an optimal puncture, use C-arm, use ultrasound, use different views, and we can very much, to a large extent, avoid this complication. Over distension of the pelvic calyceal system, again spoken about yesterday, with too high pressures can cause reflex bleeding and inadvertent parenchymal injury due to over dilatation going through and through other reasons. Now, with tract dilatation, size matters. We know that size matters in many things. Professor Rana would agree very much. We have had so many light-hearted conversations during in between meetings and during dinner. So size does matter here as well. Now this is from Yamaguchi et al. Who have demonstrated through numerous analysis that by the time your tract comes down below 24 or 18 French, the risk of bleeding largely reduces. So this is one reason why we should be choosing our renal tracts optimally, because with larger bore tracts, there is wider parenchymal injury, wider degree of dilatation, and these large tracts need to negotiate through narrow calyces, and around these calyces we have blood vessels, and these are reasons for bleeding. So we should not choose our tract size only to prevent bleeding, because that's not going to be a good operation. We should choose our tract size depending on the stone. If you're going to have a large stone, you need a larger tract. If you have a smaller stone, you will certainly manage with a smaller tract. But what we mustn't do is to use a large tract for a small stone. Now that is unnecessary risk of bleeding as shown by numerous tracts. And of course, apart from choosing an optimal tract, you've got to be very gentle. There has not been any wide discrepancy. According to data available, we have personal experiences. I have my own. I'm not bringing it to this forum. But according to widely accepted data, the type of tract dilatation instrument that we use, whether it's balloon, Amplats, or Olcan, has not shown a significant, statistically significant difference in the risk of bleeding. But the size of the tract has made a difference. So fragmentation instrument, it is a gentle operation. We cannot be aggressive. We have to use gentle manipulation and use good irrigation, ensure good visibility. If there's no good visibility, it's an indication to bail out. If you're going to do lithotripsy with a very bloody field where you don't know what you're hitting, you're going to hit a big calyceal neck, you're going to damage the mucosa. You might even go to the center of the calyx. Hopefully in the challenging cases, I have 1 or 2 nightmares that I could share with you. You're going to have problems. So be gentle, use good irrigation, have good vision, avoid irrigation or injury to the mucosa, try to avoid perforation. When you do over and over again, and when you train people, these things happen, but you must be cautious to minimize these problems. And of course, avoid pulling stones through narrow calyceal neck. So now this is another reason why I'm a proponent of relatively small tracts. So you have a big tract, you go into a calyx, you break stones through the calyceal neck. So you got smaller stones on the other side of the calyceal neck, your tract is big, you are tempted to pull, and you go and tear your calyceal neck, you bleed. So these are issues we can optimize by being very mindful of this significant complication following PCNL. So what can we prevent? We can prevent puncture through calyceal necks with better technique and better understanding. We must not overdilate and overshoot, because you're going to go to the center of the kidney where there are larger vessels and the risk of bleeding becomes higher. We must not overdilate or use unnecessarily large tracts. We can avoid acute angulation and we can avoid using disproportionately large sheets across calyceal necks. And we must always be gentle. Aggressive manipulation can result in unnecessary bleeding. So don't forget that bleeding can be either arterial or venous. Venous bleeding is fortunately more frequent and easily controlled. The judicious use of hydration, irrigation, tamponade catheters. I personally use a zero tip. I convert a Foley catheter into a zero tip, as you can see here. You understand what's been done here. And the use of tranexamic acid and bailing out if there's a lot of bleeding. I don't advocate, especially for younger trainees, to continue when there is unnecessary bleeding with a red jar full of irrigant. You stop, you put a balloon catheter, you come out. These are elective operations, and you have a second look in 48 hours and you have a very clear feel. So that's the way forward, because we must not do heroics. This is an elective operation, prevent complications. Well, in the case of arterial bleeding, it's less encouraging, because arterial bleeding, unless you have special techniques like my senior friend, Professor Rana, who will go and diatomize with the bug bee, it's not easy to control it. And unfortunately, both AV fistulae as well as false aneurysms present about a week later after surgery. The bleeding stops, the patient comes back to your emergency department with a secondary hemorrhage-like picture. You need a CT. A good CT will pick up these problems, and then you can use selective embolization. So your interventional radiologist has to be your good friend whom you wine and dine with frequently, because they are going to control this. This is one of our complications when it happens. It will happen if you do more frequently, and you need to control this. Fortunately, we have good interventional radiologists who can sort it out. So visceral injury, time is running out, so I'm going to go through quickly. It's not a frequent complication if you are judicious. Stay within your safe area, below the rib, above the iliac crest, outside the rectus spinae, most importantly behind the posterior axillary line. Now this is the safe area which gives you access without a problem. If you go in front of the posterior axillary line, the chance of hitting the colon is very high. And also remember that many of us who use C-arm, puncture is at best an optical illusion. As my diagram at the bottom shows, you may think you're puncturing, but you may be either superficial or deep. We spoke about this in the last 2 days, and if you are deep, you may well be in the colon. So you got to be mindful of it, and also the fact that rarely there are retrorenal colons, and there has to be a special caution when there's previous open surgery, because the kidney may be distorted, the fascial layers may not be there, the Gerotas fascia may be very thin, the colon may have been pulled here or there, and when there's anatomical aberration. So these are problems that always gets into unnecessary trouble. Watch out for them. There are many proponents of supracostal puncture. I respect them, and I actually admire them. But my story is, renal injury is common to urologists. Neurosurgeons never have it. So likewise, people who do supracostal punctures are more likely, I don't think there's any argument, are more likely to have pleural injuries, although it is rare. People who favor infracostal punctures are less likely to have it. Just the way neurosurgeons are unlikely to go and damage kidneys unless they're stabbing each other. So something to think about, but what works for you well, and what is safe for you is the best way to do it, whether it's supra or infracostal. So remember, there is no significant difference in position. I haven't spoken about it, but if you peruse the literature, which I'll share with you in a moment, large studies have shown that except for Staghoorns, where prone position is better, stone clearance has not seen much of a difference, whether it's any other position, prone, supine, or in between. Dilatation technique or the type of fragmentation device, although we all have personal experiences and prefer one or the other, in the big picture of statistics has not shown much of a difference. However, there is a significant difference demonstrated between giving antibiotics and not giving antibiotics. So please give antibiotics. There is a difference if you do supracostal, the chances of pleural injury or a collection is higher. There is certainly a difference between using a reasonably small, I said reasonably, not always, but a reasonably small tract as opposed to an always larger tract. So try to optimize your tract size. Obesity, immunodepression or diabetes, chronic kidney disease, and single kidneys have also shown differences in outcome, stone-free rates with PCNL. So these are some of the things you can think and also read about, which will certainly refine your practice. It has refined mine. So these are not words of wisdom. Just before I finish up, from me, these are words of wisdom I learn every day, including many that I have learned already during my stay in Hyderabad. It's not dilatation, it's the needle and the wire that harms, right? So it's not the dilatation. It is the dilatation rather. It's not the needle. So we may be puncturing bowel much more frequently, and we may be going into the IVC much more frequently with our needle and wire. I'm sure you have all seen the wire going up the IVC when you puncture. I have. It doesn't harm, but if you go and dilate into these places, you are going to harm. So be sure that you are exactly where you want to be. Sometimes you dilate outside the kidney before you go in, that's fine, but you need to be sure that you are exactly where you want to be before you dilate, and that avoids problems. Well, supracostal we have already spoken about. If you can, avoid it. If you do them, do it safely. Do biplanar imaging, so you need to go in different directions. If you are in trouble, don't use one angle. Do triangulation, or even biplanar, you go at 90 degrees where you are very sure that you are in the right place. PCNL is always at best an elective operation. Don't pursue an operation if you are in trouble, if you are not safe. Call for help. Do it another day. Do it another way. There's always another day and another way, rather than persevering with a difficult, impossible situation and getting into trouble. So ladies and gentlemen, I'm going to wind up the contents of my talk with this famous quote from Hippocrates, the father of medicine and surgery. First, do no harm. Thank you very much. And most of this information I have got from this article, which I admire so much, and its various other sub-analyses. I'm sure many of you have read it, the Global PCNL Study. And just to talk about similarities between Pakistan and Sri Lanka, you know this famous image. This is the lithotomy table, which was invented during medieval times, 300-400 years ago. Well, I started PCNL like that. The trolley you see there is all what I had when I started PCNL very recently, because we were having all sorts of problems during the war. But if you persevere, the next thing I did was to modify a non-loosened table into a loosened table, putting Perspex on it. But the pictures you see on the other side is where we are today. We have our own hospital, we have state-of-the-art laminar flow theaters, we have all the technology, because like SIUT, like Aga Khan, like many of you, when you do work and when you convince people that you are doing good work, there's enough people either from the government or from through philanthropy who are going to help us. So remember that, I always remember that it is important to finish at the right time. Often many of us are not blessed to start at the right place. So we learn through interaction. You can see people from all continents. My guru, Graham Watson, from the Institute of Urology at some point in London. People from China, I'm sure you know some of them. There is another, they're all fellows and juniors from Oxford, from Sierra Leone, from Nigeria, from Ireland, from the Middle East. So we all meet in Colombo once in 6 months. We used to meet in Colombo before the COVID, and hopefully we start again with many of you visiting us to interact, share ideas, and learn from each other. This is our team of nurses whom we value very much, and technicians. So they all learn with us and we have a good time, just the way we are having in Hyderabad. And I hope that you can all come. And before I wind up, I also want to carry the message of the Asian Urology Surgery Training and Education Group, in which I am a faculty member. Now this is a highly sponsored initiative which comes from East of Asia, and I do hope that with Professor Hamadata's intervention, that at least some of us and some of you can participate in these very high-tech courses to improve our techniques in surgery. So thank you once again, and thank you for your patient listening.
Thank you very much, Professor Srinath, for your wonderful lecture, and thank you once again for coming all along from the Sri Lanka over here, as we are short of time. So we'll move on to the next speaker, and these two will be the case-based discussion So minimizing absolute open surgery indication in neurourethriasis, I would like to invite Professor Shehzad Ali, Jinnah Postgraduate Medical Institute, Karachi, for his talk.
You ask the question and also give the same answer from your side.
So good afternoon, Chair, dear colleagues, and first of all, my question from Dr. Srinath. I'm sorry, Dr. Srinath, what is your experience regarding the Doppler use before you make puncture?
I don't use it routinely because I'm not good at it, but people who do have training in Doppler do it very well. Like we saw yesterday, some people do it only with ultrasound.
Do you think this is beneficial?
I think so. Unfortunately, I'm not good at it, so I don't use it. So people who can use it, the new generation, yes.
Thank you very much. It was very good presentation. Good afternoon again, Chair, faculty, my dear colleagues. My topic is just routine topic and just bore topic. First of all, we discuss a bit a scenario. 30-year-old male presented with the complaint of right flank pain radiating to right groin for 3 months. It was associated with lower unit symptoms as well. Examination was unremarkable and labs were also normal, except culture was positive, and ultrasound kidney ureter bladder revealed right renal staghorn stone plus upper ureteral stone plus dilated ureter and vesical stone. So this is the X-ray kidney, ureter and bladder. Usually we see these type of patient in our routine practice with different mix, and it is not unusual patient. Staghorn stone in the kidney, stone in the upper ureter, a big stone, and a smaller stone in the lower ureter, a respectable size stone in the bladder, like 2.5 centimeter, I think. So usually our way forward in these type of patient is that we do litholepexy for bladder stone, we do ureteroscopy for lower ureteral stone, we can do laparoscopic ureterolithotomy for upper ureteral stone, and we can go for PCNL, stage or single sitting for renal stone. So the whole endoscopic or minimal invasive surgery armamentarium is deputed for this single patient to clear the stone burden. But this was not the case 2 or 3 decades ago. At that point, we would choose cystolithotomy for bladder stone, ureterolithotomy for ureteral stone, and pylolithotomy for renal stone. So nowadays it's all miss. Mister has gone. So, but it's not just miss. What is the role of open surgery in this minimal invasive surgery era? This is the big question. This is the routine list that Dr. Majid Rana does, routine list Dr. Manzoor Saab does in his operation theater. Now my question from Dr. Majid, Dr. Manzoor Saab is that, okay sir, you do all these cases, but would you allow anyone to do the list, your list, but who does not know the open surgery? ओपन सर्जरी नहीं आती लेकिन एंडोस्कोपी वो कर लेगा. Is still very much relevant, although we do not do.
Yes, because you know, as a endoscopic surgeon, you can fade to do the PCN.
So at any point,
or even laparoscopy. So open surgery, it's important to learn.
Very
For
good.
every,
Sir. You are my teacher as well. You have been my examiner. Sir, thank you.
I think there is an issue going on here because it is not Dr. Manzoor, it is SIUT being represented here. And in the beginning when me and Dr. Zafar Zaidi, are you sitting here? When we started doing PCNL, the incidence of open surgery in SIUT in early 2000 was nearly 17%. And
17
means every 6th patient will undergo roughly open surgery, and that was the data they presented themselves. And in the meantime, when we started doing PCNL at the Kidney Center, and we embarked upon on one issue, what was the international guidelines, and at that time the room for the open surgery was up to 2%. In the new recommendation, it has gone down to 1%. So my suggestion is simple, that either we have our own guidelines or either we follow the guidelines. The simple is, the conclusion is that when we do an evidence-based surgery, we have to have our data comparable to the rest of the world, basically. And if you see really that after around 15 years back, in Punjab, the general surgeons doing urology by open methods, they used to call themselves urologists. But I think the peer pressure in last 15-20 years has forced the Punjab basically to change into endoscopic surgeries.
Yes, sir, very right.
I just would like to mention that the peer pressure was created, and I'm grateful for the people of Punjab. It was created from Karachi. And I just want to mention most humbly that yesterday night only about one of the residents asked me, and I have conducted only 23 workshops in Pakistan only in the last few years. And that indicates that how much is the desire to learn the new techniques in Punjab, in KPK.
Sir, desire is very much. Sir, no question about the desire. The problem is that would you allow someone to do the PCNL who does not know how to open the patient up if the need be?
You see,
this is the question.
मैं आपके क्वेश्चन का जवाब सिर्फ ये दूंगा. देखें, there are multiple things. The Learning Act, we have a philosopher sitting there. It is not go individually. It, you know, the multifaceted issue.
Dr. Shahzad, we are running very short of the time.
Sir.
So I think.
Thank you very much.
No doubt it is still in our part of the world open surgery is viable.
Yeah. This is the point that I wanted to highlight before my esteemed colleagues and chair, that although we promote the MIS very much, we do the miss very much, but we should be able to impart the knowledge of open surgery as well to our students, so that they should know how to do pyelolithotomy, how to do ureterolithotomy, how to do TVP, etc. Thank you, sir. Open surgery, this was the queen of the last century, and the biggest advantages attached to it were availability, reliability, easy learning curve, little instrument requirement, and cost effective. So in the third world, the open surgery was very much common. The disadvantages were hospital stay, morbidity, ugly scar mark. Some disadvantages were also advantages. Like patient's attendant would go to the patient and who is recently operated, and he will usually ask, "Aapko kitne टांके लगे? 12 लगे. Oh, मेरी मामी को 14 लगे थे." Oh, very good. So the bigger the number of the stitches. Reasons of open surgery regression. What were the reasons that we slowly backed out from the open surgery? Innovation and evolution in the open surgeries are very limited because the innovation were made in the types of the incision, site of the incision, number of the incision, wound closing methods, and nothing more than that. Full stop. Probably it provoked the philosophy of minimal invasive surgery. The saying was, the philosophy that created the minimal invasive surgery, that produced, the philosophy was, disease that harms should have treatment that harm less. Full stop. So the minimal invasive surgery was fulfilling this requirement. This thinking gave birth to minimal invasive surgery. The space of open surgery shrunk, and it shrunk further and more. It was nowadays used for large stagnant stone requiring open surgical nephrolithotomy, but this domain is snatched by the laparoscopic nephrolithotomy. Pyonephrotic kidneys due to stone disease were usually operated by the open incision, but nowadays laparoscopic surgeon would say that put nephrostomy catheter first, and then when we can do the laparoscopic nephrectomy, etc. Nowadays, the minimal invasive surgery treatment is in fashion because of the smarter instruments and the quality of the optic system and the introduction of the laser. So everyone wants to get operated by the laser surgery. मैंने laser के साथ operation करवाना है. The timeline of the minimal invasive surgery is that it started from 50s, 60s of the last century, and now it is full-fledged in fashion. Ureteroendoscopic surgery came into being in 1980s, lithotripsy came into being in 1980s, and likewise PCNL and other minimal invasive surgery. Now the era is robotic surgery. I am robotic trained, but we do not have robot. Now, like Dr. Majid Rana said, in areas where endourological surgery is widely available, open stone surgery is performed in the patient less than 5%. And in developing countries, open stone surgery rate have dropped from 26% to 3.5%. So, in this pic, one man is holding needle and the other person having major artery instrument. So, whenever we look at the guidelines, we see that in the guidelines, minimal invasive surgery is being compared with the other minimal invasive surgery. There is no guideline that compares the minimal invasive surgery to open surgery. In fact, this is our need, this is our requirement. If we just stick to the guidelines, like in this proximal uterine stone, see the options mentioned are minimal invasive, number 1 or number 2, A or B. And likewise, in the kidney stone, lower calyx stone, lower pole stone, upper pole stone, minimal invasive surgery is being compared with the other minimal invasive surgery, not with the open surgery. So what is the role of open surgery? I thought a lot. The role of open surgery in this era is like we are driving from the Karachi to Jamshoro by car and we are having stepney in our dicky, so that in case so there are many papers who mentioned that the PCNL is better than the open surgery, like this one from the Iran. There are many papers from the China who compared that. They also mentioned the same thing. Also, laparoscopic urolithotomy, which was previously objected that why do you do the laparoscopic urolithotomy, you just push the stone back and do the PCNL. But now the world is convinced and we are doing it since 2010. So, recent advances in the minimal invasive surgery. There are few more advances has been introduced in the minimal invasive surgery which are beneficial for the new surgeons. Balloon containing ports to avoid unintentional dislodge. Insufflator keeping uniform pressure so avoids telescope blurring. Improved endovision with high definition, ultra high definition 4K, 3D endovisions are available. Improved lights are available. Robo arm like flex dex arm is available. Without robot, it like needle holder. It is robo arm. Flex dex. अगर आप Google करेंगे तो आपको नजर आ जाएगी. Formal robot. If you cannot afford the robot, you can enjoy the robo arm. Now the problem with the minimal invasive surgery has got certain problems. These problems are economics, deltoid problem, weakness, deltoid fatigue, neck, back fatigue. There is no haptic sensation. Depth of vision was not present in the 2D era, but now in the 3D era, you can enjoy the respectable depth of vision. And the other problem is indirect vision. You are not seeing the organ directly, you are seeing the monitor. Loss of triangulation, nodes. If you are a very heroic surgeon, you are doing the nodes, there is no triangulation. Steep learning curve, difficult to learn. Cost, these R gadget would cost very much. Robotics. One thing about the robotic is that it is not necessary that you first learn the laparoscopy and then you resort to the robotic. You can learn robotic directly. Number 2 thing is that if you are a laparoscopic surgeon, yes, you have got a certain advantages while you are learning the robotics. These problems which I mentioned here, this is the list of the problem. These problems are obviated while you are using the robot. Da Vinci system started with SI, XI model, and then the newer models X and XP And this is the figure which is shown here. This is not complete robot. This is the
Dr.
composite arm of the robot.
Dr. Shahzad, please conclude your presentation.
Aakhir. So this is the complete robot, Da Vinci robot. And this is a Vercius robot on which I am trained. And this is again Vercius robot. So advantages of robotics. Sir, last 1 or 2 slides. Less fatigue, ergonomics advantage, no fulcrum effect. You know fulcrum. No counterintuitive degree of freedom, shorter learning curve. Robot is very good thing to operate. 3D vision, 360 moment can be enjoyed. Conclusion. Advances in minimal invasive surgery limited the role of open surgery, but a bigger but. Open surgery should be known to every urologist, especially in our country. Thank you very much.
Sir, one comment from my side, that we are doing our surgeries in the periphery, where there's a big resistance that no laser surgery, we want open surgery. Because as you know, as you said, that there are problems with the open surgery the same as with the endoscopic surgery as well. Because some of our colleagues are doing, they are not fully trained, so there is the problem of the residual stones. So then the people are afraid of the PCNL and the URS, because no doubt endoscopic surgery is the best option for the stone management. There's no doubt about it. But still, as you know, the people are not willing to go for this in the periphery, especially not in the Karachi, Hyderabad, or Lahore and Islamabad, but in the periphery where we are working. Thank you very much, sir.
So we have to assess the feasibility of the surgery. Yes, feasibility.
Oh, okay. Thank you, Professor Shahzad, for giving stressing on the role of open surgery, and a very good example of we should have a stepney in our car, but the new Japan cars has also gel puncture. So the open surgery training and learning, we should stress our residents and should include in our training process that the resident should learn open surgery as well. Now,
can I just add a comment?
Okay.
Which one sitting here would allow somebody to do an open surgery on you? You and your patient should be equal. So we teach our trainees open surgery just because they need to know, but we are not willing to subject ourselves to open surgery. So if Shahzad, if you just had a gallbladder surgery, if you had agreed to open surgery before lap chole, it would have been, I mean, you cannot blame poor training that you leave stones behind. That's why in periphery we do open surgery. You cannot blame poor training. It is the cause is poor training, A. B, you cannot subject your patients to just for them to be able to learn the procedure to go through it. Will any general surgery trainee will actually learn to do open gallbladder? They will all learn to do lap chole. If it fails, yes, there is experience. A lot of things are going to go away. There was a lot of type of surgeries which happened in 60s and in 50s that stopped. So we cannot say that yes, it's a stepney, we should learn it, but on who? On a patient? Not fair.
This will be a big discussion, sir. I'm sorry, sir. Sorry, no. हाँ, ये आपस में बात कर लीजिएगा बाहर जाके.
Now I invite Professor Majid Rana, the pioneer of swine PCNL, his talk on variant anatomy and management of urolithiasis.
Thank you very much. Bismillahirrahmanirrahim. Thank you very much for the organizers. Dr. Kashif called me and asking for me to give a presentation which I presented in 2007. So this is one of my oldest presentation I'm talking about. And actually I would like to point out, if you can read this thing, and the last line is uniformity in heterogeneity. And while you are reading this line, if you look at the panel of the chairman, I'm extremely humbled by this group of gentlemen. They are actually representing the 4 constituent provinces of Pakistan, starting from KPK, Professor Liaquat, and then Jalbanis. They are Baloch basically, although Saraiki region and Zakir Rajput are original true Sindhis, and Dr. Khalid from Punjab. So I am actually blessed that I've been honored to speak in the presence of whole Pakistan. And that's what my topic is, because, and I got it published, I think the date given is given, it was 2009. I gave a presentation in Kidney Center in 2007. And by that time, this was one of the largest series published about the renal anomalies. Although it was a case-based discussion, but we all are feeling hungry. I will quickly run through that. And that is the most important thing, because my message to my juniors is that most of the senior professors are sitting there and right there. Eventually, you will be replacing us. I think we need to understand that we are not in it for the income. We are in it for the outcome. And the outcome is better, our future is secured. So we all need to, as a teacher, as a professor, we need to really emphasize on our outcome. And this is my philosophy, basically. And especially, I think, in this region of the province, whole really sort of impresses you. I'm a single hole surgeon. I always try to ensure that I make one track. Very occasionally, I have made more than one track. So that is the term I point, that whole as a whole should suffice. And generally, it has really helped me. Really, as I said again, that I don't need second puncture tract. The upper urinary tract is the most common human system affected by congenital anomalies. These are data, obviously, I'm sure you all have gone through. 3 to 11% of the population account for all 50% of the congenital abnormalities of the kidneys. Congenital anomalies of the kidneys and the ureter disorder range from simple variants with no clinical significance to complex anomalies that may lead to severe complication and death. Anomalies may occur in the number, position, shape, size, and rotation of the kidney. Structural, positional, and vascular anomalies are the most frequently reported, and rotation anomalies are rare entity, and sometimes they go unrecognized. Anomalies of the renal position occur because of the defect in the cranial migration. And as you all know, I'm quickly skipping this slide. This is about the fusion. PCNL has established its mark as the most effective and sought after treatment for renal stones in normal kidney with a success rate of up to 88%. But there are fewer reports in regards to those calculi in anomalies kidneys being treated by PCNL. And this is actually I've taken from my own paper. I'm sure things have changed now. The other horseshoe kidneys were the most common kidneys by that time, which were done through PCNLs. PCNL for stone disease in anomalous kidney appears prima facie to be of a great concern due to multiple factors. Number one is a malrotation, malformation, and malposition. Abnormal renal and calyceal orientation, abnormal relation of the calyces to the renal pelvis in the upper ureter, and the relative renal immobility impeding the maneuverability of the equipment in relation with other intra-abdominal organs, and abnormal dispensation of the renal vasculature. These are the most important concerns when we are dealing with the variants of the renal anatomy. In all recent studies, there has been an exaggerated emphasis, and that is my point I've been emphasizing yesterday also and day before yesterday here in various workshops, that in all recent studies there has been exaggerated emphasis on the calyceal preference for the puncture and tract creation. But as it is evident that in anomalous kidneys, IVU and CT pyelogram does not demonstrate exact demography of the calyces. Therefore, decision for the choice of the calyx for the tract creation is eventually finalized only on the table while processing dynamic fluoroscopic visuals of the retrograde urography. And even in a normal PCNL, I would emphasize that do make a plan for your puncture and the preference of a calyx, but the real decision should be made on the table in the real-time retrograde studies. These are various abnormalities. I will skip through. This is the development. As we all know that this happens at the 4th week of gestation. The kidneys have pronephros, mesonephros, and metanephros, and where the abnormalities take place by the end of the 9th month. So these are various pictures just for the sake of completion. I'm skipping through that. This is a classification of the variation of change position and malrotations, just added for that. What are the technical challenges actually in these variant kidneys? Number one, in congenital urinary anomalies, difficulties in access, need for multiple punctures, and a need for auxiliary procedures are of paramount relevance. And technique, puncture, access, exit strategy, and complications are the real challenge. Now, I will be showing you that what happens, and there is only one question I will be asking you if you can judge what is happening here. As you can see that there is a stone. I think on that side you can see that. I'm not wasting time in looking out for a pointer. And you see totally non-dilated system is here. We did a PCNL, and if you see that underneath, what is happening, that white thing is simple. Our great resident did not look into the catheter and kept on giving solifin to the patient, and that catheter was kinked. So it is the bladder, and when we saw, because in our center, in kidney center, we had a protocol that 7 o'clock in the morning, patient will have an X-ray. So once he saw the X-ray, he realized what is going on. He just removed the kink and patient was comfortable. But, and bifid pelvis, as you can see that, this is a plain KUB. And you can see that, and the stone is gone. Polycalicosis. I'm just showing you quickly, going through the slides, that things are possible to be done once you have a resolve. I see that what is happening. And this is the X-ray going on. Fusion anomalies. Horseshoe kidney, I'm sure many of you have not only done it, many of you have seen it as well, and you have all geared up to do it, because this is one of the most common anomaly we encounter. These are various types of rotations, and this is, as you can see, the right kidney. This is the rotation going on, and we landed straight away on the stone. Anomalies of the renal fusion, and this is wonderful. This is our first time. Dr. Fazedi was there at that time. He was almost learned his laparoscopy. So this was the procedure in a pelvic kidney, that we reflected the mesentery in the colon on the right side, and under vision the puncture was made, and PCNL was done under vision, and the kidney was made to be shown by laparoscopic measures. And this was the IVU, and this is the outcome. Cross-fused renal ectopia. This is KUB. You have no idea what is going on. IVU has been done. The outcome. So the application of PCNL as comprehensive procedure for large and complex stone in adverse renal diversity such as fusion, rotation, malformation, malpositions yields safe and comparable results, demanding firm resolve on behalf of the surgeon to confront these challenges. I know that on prima facie it appears very difficult, but eventually once you have enough experience, probably you will be able to do it. Yeah, this is the saying. I think, as I said, that we are scientists, we have to practice science, follow the rules. So there must be some rules. Therefore, certain rules are here set forth, which as they are few in number, so they are plain and easy to be understood. Follow the rules, obey the command, and come up with a positive outcome. It is better to change an opinion than to persist in a wrong one. ठीक है जी, अपना शहजाद अली साहब ये पढ़ लीजिए, आपके लिए है ये. This is my belief all along. Quran says that لَقَدْ خَلَقْنَا الْإِنسَانَ فِي أَحْسَنِ تَقْوِيمٍ. We have made you, we have created you from the best of the components, and Allah subhanahu has chosen us to treat the best of the man created by the best of the components. So I would say that reserve the best reserved for the, hence the man deserves the best, so reserve the best for the man, and it can only be through you. So you have to really excel. And mind it, urology is not a very diverse and a very big field with all super specialities. So I think probably as you have to follow your mentor to come up with the outcome which is comparable with the results of the world. And I say thank you very much. So I was so quick and brief. Thank you very much. Thanks.
Thank you, Professor Majid Rana. We can take one or two questions, if any.
Not just CT urogram, rather you should look at the vascular anatomy, a CT angiogram as well. And then you can plan and you can take a final decision at the time of surgery when you do a retrograde. But most of the planning has to be done before with the help of extensive imaging.
Yeah, I think I have an opinion that rather
aberrant vessels are.
You see, the either you are preemptive, you are doing too much of investigation. Yes, you have every right to do that, and probably IVU CT scan has been done, and as long as probably you are not very worried that the issue is the abnormal vasculature, and that is the most concern basically. But usually as a routine, we were not doing it. So if you think the facility is available and you just want to do it, I will not object to that.
Thank you very much, Rana sir. We are already running short of the time, and the lunch is also ready for there. I am really thankful all the presenters who have presented their presentations on time, and they were very much informative. Thank you very much.
Thank you once again, everyone, for up to this session, and due apology for delay for 1 hour since morning. So please, we are having lunch after this presentation, finish it, and please, if we gather as early as possible, so we can able to start other session as early as possible. Thank you very much.